I guess you're supposed to hold that.
Well, good afternoon, everyone. Well, wait, let's try that again. Good afternoon, everyone. There we go. Well, I'm Stephen Cohen. I'm a professor of business communication at the Johns Hopkins Carey Business School, and I'm thrilled to welcome you to today's special event on entrepreneurship and healthcare innovation. Let me begin by thanking my co-organizer, Professor G. Bai. Let's give G a big hand. And the amazing event staff at the Johns Hopkins Carey Business School and the Hopkins Bloomberg Center. Your hard work made this event possible. We're fortunate to have an exceptional group of innovators and change makers with us. Over the course of 3 panel discussions, our speakers will share their insights on careers, on entrepreneurship and healthcare innovation, as well as the future of the U.S. healthcare system. During the final 10 minutes of each session, you'll have the opportunity to ask questions and engage directly with our panelists. If you'd like to ask a question, please line up at one of the 4 standing microphones when we begin the Q&A session. Today's panels provide an exciting opportunities to hear from leaders at the forefront of healthcare and entrepreneurship, offering valuable insights that can inspire and inform your own work and ventures. Before we get started, please make sure your cell phones are silenced. Thank you. And now it's my pleasure to introduce the Dean of the Johns Hopkins Carey Business School, Alex Triantis, to deliver opening remarks. Alex?
Thanks, Stephen, and welcome everybody to Johns Hopkins University, to the Carey Business School, and to this magnificent Johns Hopkins Bloomberg Center here. It's really exciting to welcome you all. I see students, alumni, faculty, staff, and many community members as well. So thank you all for being here. So today's all about entrepreneurship and innovation. So let me tell you a story of a startup. This story goes back 150 years ago. Some of you know which startup I'm talking about. A man named Johns Hopkins decided that he was looking to disrupt the education industry here in the United States. And he bequeathed money in order to be able to set up a university like no other university here before in the United States that would really bring together education together with discovery and innovation. And unfortunately, the money was given upon his death, so he didn't get to see it. But we know 150 years later what an incredible impact it has had in terms of all the innovations that have come out of this university, but also the fact that so many universities follow this notion of tying education together with discovery and innovation. Let's fast forward many years to 2007. A gentleman named Bill Carey decided that he wanted a transformative and innovative business school, and hence came the Carey Business School. Bill Carey's ancestors were actually friends and colleagues of Johns Hopkins, so there was a close tie, and he really wanted to have a great business school in the city of Baltimore and in Maryland and in this area, as well as one that would operate differently, do something out of the norm of legacy schools. And so on we went over the last 18 years, and one of the areas in which true innovation is taking place at the Carey Business School is a focus on what we call the business of health, understanding that every part of the health ecosystem could use some better business principles, could use some disruption and innovation. And that's what we do. The business school working together with the School of Medicine, with Bloomberg, with the Bloomberg School of Public Health, with nursing. And we have 150 faculty working in the Hopkins Business of Health Initiative, trying to figure out innovative ways to do everything from operations to the economic structure that you'll hear a lot today around the health ecosystem. We also, at the Carey Business School, try to be very interdisciplinary, try to work across silos. So right now, many of you know that Hopkins is making one of the largest investments in artificial intelligence of any university in the world. And here at the business school, we recognize that all organizations and businesses are going to be transformed by AI and other digital transformations, and we want to be at the forefront and educate our students to be prepared for that. Beyond that, we also are here in DC, where Carey Business School also operates, and in this building, we have the School of Advanced International Studies. It's been around for 75 years, trying to understand geopolitics, and in our case in particular, how does that marry and affect with business? We also have another startup, the latest startup at Hopkins, which is the School of Government and Policy, also in this building, that just is being formed as we speak. So it's a very exciting place. This is the richness that Hopkins has. 4 decades of leading the United States academic industry, if you like, in R&D, and having incredible impact through the impact on business and society. Now, when it comes to the intersection of business and health, we know that the task is sort of straightforward. How do we get better health outcomes? How do we get them at a lower cost? And how do we make it accessible to all? Straightforward proposition, but trying to understand the value solution is not so easy. We've got $5 trillion here spent in the US on healthcare, and yet we're not getting the outcomes that we desire. The innovation taking place in medicine and science is truly transformational. It's mind-boggling to see on the diagnostics, on the therapeutic sides, what is happening here at Hopkins and at all the other academic institutions and within corporations here in the US and abroad. However, innovation only can be adopted as fast as the infrastructure around it can adapt. And so I'm sure we'll be talking about a couple of issues around that, the ecosystem around innovation and how it is supported here in the United States and abroad, and also the policy, which, as we know, is hugely and hotly contested here around healthcare and has such a great impact on the adoption of innovation that is ready to transform the healthcare system and the lives of so many. So I'm very excited for this afternoon's discussions, and thank you again all for coming here, and I'll turn it back to Stephen. Thank you.
Well, thank you so much, Alex. Appreciate your remarks. Well, I'm pleased to introduce the speakers on our first panel. Closest to me is Bill Gurley. Bill is a general partner at Benchmark, a leading venture capital firm in Silicon Valley. Over the course of his venture career, he has invested in and served on the boards of many companies such as Nextdoor, OpenTable, Stitch Fix, Uber, and Zillow. Born in Dickinson, Texas, Bill earned a bachelor's degree in computer science from the University of Florida. Go Gators. Good choice, Bill. My alma mater as well. And later received an MBA from the University of Texas at Austin. In 2025, he received the Distinguished Alumnus Award from the University of Texas Alumni Association. For over 2 decades, Bill has written about technology and other subjects on his popular blog, Above the Crowd, and on his social media accounts. He's the author of the new book, Runnin' Down a Dream. Congrats on that, by the way. He's joined on stage by David Epstein. David is the author of the #1 New York Times bestseller, Range, Why Generalists Triumph in a Specialized World, and of the bestseller, The Sports Gene. He has been an investigative reporter at ProPublica, where his work spanned drug cartels to poor medical practices, and a senior writer at Sports Illustrated. He has master's degrees in environmental science and journalism. David will interview Bill about his new book, Runnin' Down a Dream, How to Thrive in a Career You Actually Love. David, over to you.
Thank you very much, Stephen. Thank you. Bill, I want to start with the obvious, my personal single most burning question for you, given all your achievements, which is, how did you get so tall? No, really, we were both college athletes, but clearly not in the same sport. No, I want to dive into your book, which, by the way, Running Down a Dream, How to Thrive in a Career You Actually Love, available for pre-order, so I'll repeat the name several times so you can search it.
I found out you can just type Gurley and Dream into either Amazon or Google, and you get right to the
Now you have no excuse. But so this book is very much as it says in the title and subtitle about finding something you're passionate about. Why? What was the genesis of it, and kind of why now? How do you see it sort of meeting the moment right now as people try to navigate this very fast-changing world and find?
And by the way, I mean, he already gave an incredible intro of David, but I'm thrilled that David was able to join me here today. His both those books, if you haven't read them, you should read. I think the second half of Range is like one of these must-read books that everyone has to really like devour and understand this kind of thing that happens, this magic that happens when someone can cross-pollinate from one industry to another. Anyway,
Thank you.
I would highly encourage everyone to read that. So thank you. The book came about. There was a period in my life where I was devouring biographies, and I think a lot of people find them at that place in life. And there were 3 particular biographies of people. They were all in very different fields where I noticed a pattern of things that they had all done that could be systematized. And I, as a venture capitalist, I think a lot of people say venture capitalists are in the business of pattern recognition. You see 100 pitches, you only fund 1. You start looking for the things that stand out. And I've also been this blogger over the years, writing these pieces when I've kind of had an aha moment. So this notion of something popping into my head and saying, oh, I should write about that, was something that I had kind of developed. And once I saw it, and the other thing that was interesting is one of them was a basketball player, one of them was a restaurateur, and one of them was in folk singer. Those are not industries your parents would tell you to go get jobs in, yet they were all wildly successful. And so it was something that developed as a passion project. I originally just did it as a university presentation in a room very similar to this. After that, a few things happened. People started talking about it. James Clear saw it and posted it on his website, and people started nudging me, you should make a book. And one day someone nudged me in a particular way where I did it. And so I was kind of off into the races. We spent 6 years turning it from a presentation to an MBA class to a full-fledged book, and did a lot more research. What I've come to understand today, I think the unfortunate reality, I mean, leaving AI aside, our kids are caught up in this, Jonathan Haidt calls it a resume arms race, but starting around 12, parents freak out and they start worrying about what their resume is going to look like on that college application. And hence, you know, the kid's life gets full of lacrosse classes and cello lessons and sports teams where you fly across the country at 13 years old. And there's not a lot of time left for exploration. We had a chance to talk to Angela Duckworth while we were writing it, and she was, you know, grit had 2 components. One was passion and one was perseverance. And she said if she could write the book over again, she'd focus more on the passion side, because we've trained the kids to persevere. We've trained them to grind, but one day, all the grinding, all the nights, all the work, they wake up and they're just stressed out and they realize they don't love what they do. And so the purpose of the book really, and I don't think it's for everyone, but for people who need that little push to go chase their dream and do that, maybe chase that occupation that well-meaning parents would tell them not to do, I want to give them the tools to do that, the permission to do that.
I think you touched on a few things I want to go back to, but I would argue that this book may be for everyone. It didn't feel to me like something that might be especially valuable for younger people, but it also made me, I mean, I'm finishing up a project now, think about, well, because the book is clearly about following your passion, right? But I think it's more than that. I think it's about paying attention to things that help you figure out what that passion is. To me, it's about paying attention. Like, you tell this incredible story about the restaurateur, Danny Meyer, and it's like he grew up traveling with his family, and his mom made him keep a journal. And so he did that, you know, and he went into other jobs, and he worked in sales, and he worked on a political campaign and all this stuff. And then he was going to take the LSAT. He wasn't really in love with any of it, and he starts going back. He's looking at this journal. It's like, well, on family vacations, he's always writing about the food that they're having. And while he's working on a campaign and traveling. It's all his memories are, of the restaurants he visited. And it doesn't even occur to him until, I think it was his uncle.
His uncle, yeah.
Who says, obviously you should start a restaurant. And then it's like, you see all these antecedents in his life where the passion was there, but he kind of wasn't paying attention to it in the right way to grab onto it.
Right. And look, I think the unfortunate reality is a lot of parents and guidance counselors, once again, well-intentioned, worry about the economic stability of the life of the developing young adult. And so they encourage jobs that are, supposed sure things. And now in the AI world, some of those sure things, I mean, comp sci went from being the most sure thing to the least sure thing, like overnight. But I think there's a better question than whether it's a sure thing. Like, do you really love it or not? Like, I don't think we should be sending people into careers they don't love just because they're safe or economically better,
Yeah, but what I again found fascinating about the book was it was very much showing how these other people found ways to pay attention to those passions. Like even with your own story. And let me go back to two other things you said first before I continue that. One, you mentioned youth sports, right, where people are spending more time traveling than actually playing, because I think that is emblematic of a lot of the rest of the stuff. Last I lived in New York, I lived across the street from the meeting place of a U8 travel soccer team, right? I don't think there's a human being on the planet that thinks 7-year-olds can't find good enough competition in a city of 9 million people that they need to travel, right? But it's because that adult is trying to kind of prey on the parents' insecurities, say, well, if they're not on U8, they can't be on U9, et cetera, et cetera.
Yeah.
And I think that's just emblematic.
Yes.
Like the kid, you don't know if that's the best fit for that kid or that sport, right? The earlier you push selection, the more likely you get the wrong person and the wrong thing. And to go to Angela Duckworth, I was just in her class recently, and she was developing this idea to her students she called the paramecium principle. I don't know if you've heard this one yet, but it
We have it in there, but yes.
Oh, right, of course, sorry.
No, it's all right.
And where she's saying, well, a paramecium, I guess it sort of decides which direction to go by it senses food or it senses warmth.
Yeah.
And it then just pivots in that direction. If there's more in that direction, it goes in that direction.
Right.
If there's more in that direction, it goes and keeps following, which is an interesting adjustment of just the grit concept, right? And so that really bled through the book, that paramecium principle of not necessarily, like you can have long-term goals, but to me in some ways it felt like a book saying, don't be beholden to those if you start learning other stuff along the way that you're interested in, like pivot.
Absolutely, and I'll get the numbers wrong. I should have them in front of me, but Dave Evans, who teaches this class at Stanford, Designing Your Life, in their book by that same title, they ran a study, and like I'm not going to get them exactly right, but like 5 years after college, 40% of people are no longer in an occupation related to the major, and then 10 years after, it's down to like only 40% are still in it. So in addition to maybe not forcing someone into a particular occupation, realizing that just because you have a major or just because you started a career in one direction doesn't mean you can't pivot 180 degrees from that if you feel you should be doing something else.
Yeah. Well, I studied geology and astronomy, which was perfect for getting to Sports Illustrated. So, so I don't know what you're talking about. But your own story, I think, you didn't want. I know we were talking about this before, that when you pitched a book, because of your prominence, agents were. It's got to be your memoir, right? Yeah. And that's not what you wanted to do, but you do put your story at the end of the book, in short, not at the length of some of the other stories you profile, but I think it's a beautiful coda, and you sort of embody some of the tenets in the book. Like you start off, you have a successful engineering career at Compaq, when Compaq was like the disruptive, cutting-edge company. And despite the prestige and your success, I think the phrase you used was that you were developing a sense of future boredom.
Yeah,
I think that was the sense. And how did that develop? Because by all objective view, it looked like you were on this great path on the cutting edge company, and yet you're paying attention to these signals. What did that look like?
Well, I was an engineer, and I loved programming. I loved comp sci. I thought it was what I wanted to do, but the development of a physical product at a company like that, you let a model go out the door and then you start developing the next model. And by the time the third one was going on, once I was there, the project cycle was very repetitive from the other. I mean, the Intel processor was a little faster, the clock speed was a little higher, but all in all purposes, we were going to do the same dance over and over again. And that's where I thought to myself, well, I don't want to do 12 of these. And so I started thinking about other things. I was also, I had started investing on Prodigy of all things. So, and I'd read One Up on Wall Street. A lot of it comes from books. One of the things, one of our 6 principles in here is about, it's titled Hone Your Craft, but it's about lifelong learning. And one thing that I think a lot of people do, the minute they get in the door at a career, they kind of stop external learning. And external learning to me is you in your spare time, when you're not at work, you're developing your craft even further. And I think there are some industries where that's kind of known that you do that, but I think most industries, people don't do that. And I think in the book, the very first chapters on, do you know what your passion is? I think a lot of people don't. Like, I don't think and I'm not sure you can just like force it upon yourself. But I think the test of it is, do you love it so much that this external learning feels like fun? Is this something you would research on your own time and maybe not watch the next episode of Breaking Bad? Like that's the test. And so I know how to know someone's not there.
Yeah.
Or
then you watch the next episode of Breaking Bad and realize your passion is meth, and that.
Yeah, well, that could
also. But again, what I really loved about it was that it has all these examples of how to pay attention to your passion, and that going back to your Compaq example, that I love that phrase, that a sense of future boredom, because you weren't even there that long.
Right.
When you started saying, I've gone through this cycle twice, I can see what it's going to look like 12 more times. And there's a ton of research that shows if people quit or change directions, if you quit at the right time in something, it will always feel like you quit too early. But you were pretty attentive pretty quickly to signals that this wasn't the thing. So how did you kind of distinguish between like the natural day-to-day frustration or a hard job or something that's repetitive versus like the realization that this really is not the calling?
Yeah, I think that, well, first of all, it wasn't to suggest that it was difficult or that I was unhappy would be wrong.
That makes it even harder, though.
Yeah. I enjoyed what I was doing. I enjoyed the journey, but I think this notion of like just really forward thinking. We have a phrase in the book. I say we because I worked with a researcher and co-writer, but we say life is a use it or lose it proposition, and what you described, like thinking forward that much, was really like illuminating in my brain, like fast forwarding, imagining 10 years, imagining 15 years, and then it was just, that was super clarifying.
So I think the book kind of argues for having that, like a reflective practice in that way of saying, what does this look like? What is it going to look like? What's interesting me and what's not? Because you pivoted a number of times. Like it really reminded me of this Harvard research called the Dark Horse Project, where they looked at how people find fulfilling work. And it was often short-term planning, right? People didn't say, here's who's younger than me and has more than me. They'd say, here are my skills and interests. Here are the opportunities in front of me. I'm going to do this one. And maybe a year from now, I'll change because I will have learned something about myself. So, I mean, you realize you're interested in business, you get an MBA, you go to Wall Street. Again, there are things you like. It's even harder because you didn't hate any of this stuff.
No, I didn't hate
right?
it. Yeah.
You're pivoting off stuff you liked. And then when you wanted to be a venture capitalist, I think the advice you basically got was, great, just do 20 years of this first. The advice was like, delay the things you know you're interested in,
yeah.
right?
Yeah. Well, the Wall Street one was different, but it had a similar mechanism for identification, which is after doing it for 3 years, and by the way, hustling on a job in Wall Street, I mean, you've read all the books, Liar's Poker and everything else. You're working 12-hour days, and you're waking up at 6 a.m. and putting on a suit every day. Like, it's intense.
That book was supposed to convince you not to go to Wall Street.
I know. Michael's very upset at how many people he sent to Wall Street. But it was very easy to say to myself, I can't do this for 30 years. Like, there's no way. Like, there's just no way.
So how did you manage that kind of discouraging feedback when you were told you have to do? I mean, was it just you just knew in yourself you just couldn't do it, so that feedback was irrelevant, or?
Well, those are two different things. So the person that said go work for 20 years was a VC who said I had to be an operator for 20 years,
Right.
which is ironic because my firm Benchmark hires people in their 20s. So I ended up at a place that had a very different attitude towards that. The thing on Wall Street was just realizing that despite this being extremely well paying and awesome in so many ways, that it had a level of stress and intensity about it that wasn't going to be something I'd spend the rest of my life on.
So do you think it sometimes makes sense for people to take a pay cut in their career when they're making their pivots, or does it never make sense to take a pay cut?
I mean, I think part of it depends on how you live your life. I've met a lot of people that would get to Wall Street and immediately get the house in the Hamptons and immediately put their kids in private school, and you're stuck. Like you have no financial flexibility whatsoever. So I think if you earlier in your career, if you live, well within your means, it gives you so much more financial flexibility where you can make those kind of moves and pivots. There are extreme examples in the book. Danny Meyer is making the equivalent today of about $250,000 as a very high-paid salesperson, the number one salesperson at a very successful company, and he took a job at 1/10 that salary to go learn about restaurants. So that's extreme.
I like those examples because I've gone backwards in like pay and title a number of times in my career, and I've always figured my best professional skill was that I only buy running shoes and books, basically. So,
There's a great quote in Rick Rubin's book, and people don't know he's one of the most successful music producers of all time. He wrote a book called The Creative Way, and he has a sentence in there where he says, every career pivot I've made in my entire life, all the people around me have told me that's the exact wrong thing. You shouldn't do that. And he said they've all turned out spectacularly well for him.
That comes through in some of the stories you tell that, or at least it's implicit, that the people telling you that, you're often asking people that are in the same area you're in, and they're staying there, right? So they're kind of like not the right people to get that advice from. You have to sort of branch out. And you talk in the book about the importance of like broadening networks and mentors and peers. And I want to talk about that a little because you organize the book into tenets, 6 tenets for running down a dream. And one of those is developing mentors. And you go through in all the stories you tell how people did that in really impactful ways. And so I'm wondering if you can share a little bit about how do you get those people to be interested in you? Do you just send Bill Gurley a LinkedIn DM or what do you do?
Well, there's a couple different things I have in the book, but one of them is I think you want to have a list of aspirational mentors that's separate from the people you're going to get tomorrow. And Danny, we keep using the Danny example, but when he decided he was going to be a restaurateur, there were 12 people that were kind of making a dent in a new way in the restaurant industry. And he made a poster board of them, and he studied them each, and he wrote down, who they are and how they're doing it and what's different about them. And so he didn't cold call those people at that moment in time, but they were out there as kind of proof points that you could go do this thing, right? And there's a word that we use in the book, disinhibiting, like knowing that other people have done something, especially if you're picking kind of a creative new career or a different career, that's really helpful. And then I think you just start around you. You start with networks you already have. I think if you start with people that are maybe 1 or 2 tiers down from the super famous people, they haven't been called and asked. They're flattered if you know about them. And so research the hell out of them. Be very nuanced in how you approach them. And then if you can, get them to root for you. Like if they give you advice, do it, and then tell them you did it and tell them it worked, and get them on your side where they feel like if you're winning, it's because of something they did, that you want them on your team, like a sports team.
Yeah, it was an interesting part of the book because I feel like I get a ton of random messages on LinkedIn. I'm sure you get an insane number of those messages, and it's like people feel they're doing the work because they're reaching out, but without having done the homework, really. There's kind of no chance. Even more so now, I would think, with the volume of messages.
But I have found, and I think there's a few places that are very special, but there's this element of Silicon Valley that if you go there and work there, I've heard from others and I've felt myself, I don't know why, it's very easy to ask somebody for 30 minutes in Silicon Valley. It's almost like so many people have done it for so many other people that there's this pay it forward obligation that's kind of in the water. And I suspect there are people there that say no, like I can't promise everyone will say yes, but I think relative to other industries, everything's so fluid, everything's so dynamic. People switch jobs quite a bit. I think it's more kind of wired that way.
Interesting.
And I benefited greatly from the fact that people would do that. And I try and do it as often as I can, to pay it back,
This gets to another of the tenets, which was embrace your peers, right, in building your network. And you were kind of, well, let me ask, does that mean like networking?
Well, so when I was in business school, I first got to business school, the word networking, people said, oh, you should go network. And I really thought it was a social activity, like they were teaching us to be social.
Right.
And in retrospect, I think now that I've studied all these success stories, I think that's not really what it's about. It's about finding people who are on the same journey as you are that you can connect with and co-learn. And there's some amazing examples in the book of this. I'll share one, probably my favorite. Who knows who Jimmy Donaldson is? Anybody? A couple over here. So that's Mr. Beast, is Jimmy Donaldson.
This story is amazing in the book, by the way. I didn't know any of this
So
stuff.
when he first got enamored with YouTube, he's like 17. He meets 3 other people who are equally enamored with YouTube, and they end up on Skype calls together 16 hours a day for 4 years in a row, co-learning, co-sharing ideas. They each had their own channel. They weren't like a team all under the same channel. And he said they all became millionaires. And he says even one thing that's even better. He says, if you had been on those calls, you could be a millionaire too. Like you being a generic person, not anyone in particular. Just because what they were uncovering ended up being so useful and valuable and so cutting edge. And so, of all the principles in the book, I think this is the one that's kind of most novel because I've never read a self-help book or a personal development book that said, oh, go get a great group of peers. And I've tried to push it in some of my companies. I've tried to get CEOs to encourage their direct reports to go learn externally and report back. And it's very awkward to a lot of people. But it oddly relates to some of the concepts in range because if you can go get 4 or 5 people who do what you do, maybe in a slightly different industry, not in a competitive thing, and meet with them, you're going to learn so many things that are going to be so helpful to your org because those are the things the org doesn't already know.
Yeah.
The stuff the org knows, it's not very super helpful to fine-tune those things.
Yeah. It's like the famous strength of weak ties research that you get your best opportunities from people sort of on the fringe of your network. And to your mention of range, I had some severe confirmation bias while reading this book, so thank you for that.
And by the way, I know range kind of evolved from this friendly co-opetition with Malcolm Gladwell. Jimmy, in a podcast on Rogan, said, they talk about 10,000 hours. He said, we kind of got 40,000 hours because we had 4 people learning and sharing back, which I thought was an interesting notion that you could somehow exponentially improve your chances, that way. And putting a numeric score on it is enlightening, I think.
Really interesting. And you were kind of extreme in the embrace your peers because you were arguing not just finding people on the journey, but share everything, like almost for not being territorial at all. Yes. Which I think is really, it's a very abundance mindset that if we do this, there'll be more for all of us because you have to be kind of vulnerable and take some risk.
And I think all those 4 people on that Skype call did that. And I think part of why healthy peer relationships are tough to build is because some people get very sharp elbowed about how they think about their skills and I benefited greatly as a professional investor from the fact that people like Warren Buffett and Howard Marks would continuously write down their best thoughts and share them with the world. And I don't think it prevented either of them from being highly competitive in their field. I think it's almost a myth that, like, maybe it's even like your own self-ego that you think you have these thoughts in your head that are so goddamn, like, importantly private, that need to be protected, that you know. And yeah, if you give those away, you're going to get far more back.
Yeah, I mean, the book made me think that you should definitely err on the side of risking sharing too much rather than not enough. Stephen, can I read one quote from the book before we go
please.
to? Okay, I want to actually, I'm going to give 2 quotes and then we'll go to some audience questions. But one that I loved was a benchmark saying you shared that said, "Good judgment comes from experience, which comes from bad judgment," which I thought was kind of fun because if people go on this journey, they're going to take some wrong turns. Right, but that idea that good judgment comes from the experience of having done things wrong, I think is a great kind of reframe. But I wanted to share just one quick passage, because there's some beautiful turns of phrase and passages in the book also. My number one objective for writing Running Down a Dream was to give everyone as much permission and as much confidence as they need to tilt against a career they love. I know what many smart, pragmatic, and well-intentioned people may have told you, that you should focus on well-paying jobs in classic industries where the risk is low. But I hope to reprogram the classic advice that work must be work and hobbies must be hobbies, and that it's best to keep those separate. It can be different. You can make a career and even thrive in a job you truly love. Life is a use it or lose it proposition. How do you want to use yours? I just thought that was a beautiful passage.
Thank you.
That.
Thank you. And by the way, I'll mention 2 things that relate to that, because one thing I hope the book takes the people that kind of in the back of their mind know they want to go do this thing, and they don't, like, they haven't been able to convince everyone around them that it's an okay idea. I really want to give them a shove and give them that permission.
Yeah.
There are 2 things I would mention. I'm carrying a book called The Last Laugh. Jerry Seinfeld, when he was young, was on a career path that was not a comedian, but he had started to do jokes. He had started to think about it as a career. And this book was the first book that covered 13 comedians in their successful career and how they did it. And just reading that book gave him that push. And then there's another one I just love that kind of reinforces what you just read. In his book, Green Lights, Matthew McConaughey he's told his family his whole life he's going to be a lawyer. And that's all he's talked about with them for career. And he's at the University of Texas. He's in pre-law. And some people convince him he should switch to film school. And he comes to that conclusion. And he then has to tell his dad. And he's like nervous as all get out. And he's like, he doesn't want to tell him, doesn't want to tell him. He's putting it off. He finally gets on the phone and tells him. And his dad says one thing. His dad says, "Well, don't half-ass it." And he says in the book, and I think this is so great, he said in that one phrase, his dad gave him a push, permission, support, obligation. He said, "Okay, yeah, if that's what you want to do, go do it, but go do it as well as you possibly can."
That's great.
And anyway, that speaks to kind of what I hope to convey.
Let's give our panelists a big hand. Folks, we have time for a few questions.
And they don't have to be about the book. We're supposed to be about innovation.
Yeah, whatever you'd like to ask. Really appreciate your being here. Got a microphone right over here. We have one up there. We have a microphone right over there and one over there. If anyone would like to ask a question, we'd love to have you. Come on down to the microphones. And as we get started here, please, whichever microphone you like would be great. A few notes before we get started here. As my old graduate dean used to say, a good question has 3 elements. Make sure to introduce yourself, keep it short, and end with a question mark. All right? And with that, let's start right over here.
Hello, and thank you very much. So my name is May St. John. Just moved to the East Coast from Los Angeles 2 months ago. I serve as the director of the Department of Head and Neck Surgery at Johns Hopkins, so thank you for your time. You know, one of the things that you both touched on that I thought was really essential from being an academic surgeon or scientist as well is the concept of really kind of giving and really being open with others. And what I'm wondering is in terms of teaching that, because we too in surgery have people who feel they're the best surgeon ever, And there's a lot of sharp elbows sometimes. And I think as you kind of think about changing culture and teaching that, I'd be very interested in your thoughts. And thank you. There's a question mark somewhere.
Okay. Have you seen anything about behavior change in that way, trying to convince people to be more open?
Yeah, some, but she wants your insights.
No, I know, but yeah.
I think it depends on the incentives, right? Like I once, this is a little different, but I once gave a talk, since I write about the benefits of being broad, to what Atul Gawande would call the proverbial left ear surgeons, right? People who are super specialized. And to be provocative, showed some data that was like showing that specialized surgeons, even if you control for the number of procedures done, if they self-identify as more specialized, they have fewer complications, don't know why. But they also do the procedure much more when it's not needed. So you're like a lot more likely to have no complications from a procedure that you never needed in the first place. And I thought they were I was trying to provoke them a little bit, right? And they were like, absolutely, we totally agree, like our colleagues need to get it together. and I think that falls in line with a body of research that people actually have a lot of trouble learning from their own failures and are better at learning from others. And I think there's some aspect of that where you kind of have to get the people out of the space where all their identity anchors rely on it. And move them around a little where they can see their situation but it not happening to them. It's like the same thing where people give, this probably resonates, it's well shown that people give better advice on the same problem to one of their friends than they do to themselves, because you can like get them out of all these other motivations that are going on. So I think we'd have to be really thoughtful about moving people, not allowing them to rely just on their own direct experience, or it's going to be very hard for them to kind of find reasons to be more humble in some sense. Yeah. What do you think?
Well, the only thing I would add is I think you got to, as you said, incentives. You need to create an environment where the people that are sharing openly are acknowledged and rewarded in that environment. Yeah. It's tough in that field, I think, because patent protection is considered tied to a lot of financial rewards, and so like the fields I work in, open source, rampant, like people don't kind of try and win with patents anymore. That makes it worse.
Great. Thank you. How about up here, please?
Hello, my name is Else Cole. I'm a healthcare visionary and innovator from Indianapolis, Indiana. And I have learned in my field, I'm following what I call my purpose, which is to protect the defenseless and give voice to the silent. And I'm just curious, I didn't read your book, so I apologize. I didn't prep
Not
ahead
out
of time, but passion and purpose, I mean, I kind of feel like they're related. I guess my question to you is, do you see a difference between purpose and passion, or do you think that's all in one?
My answer to that is I think it's somewhat individual dependent. Like I think there are some people who feel such a strong calling of purpose that it becomes the passion. I don't know how they would get away from it. Like if that's really at what's the top of their head, then I definitely think they should go do that. There were even in some of the stuff that popped up over the last 4 years, there's individuals inside a company that have a very strong calling about certain, ideals or initiatives. And some of the executives eventually said, well, you should go do that full time. And I kind of agree with that. Like, so if you have just a deep sense of purpose, I think that, and once again, I'd test it this way. Are you willing to study that externally in your free time? Like, that's my test. And then yes, 100% you should do that. I don't know that everyone's wired that way. I will tell you, almost everyone I study in the book ends up having such a big impact on their industry and is so prone to this open sharing concept that the number of people they touch is very, very broad. Like very, very broad. Almost to every single one of them, to a fault. And so for me, at least, that's a good test also. Like, do you touch the lives of others?
Thank you.
Appreciate that. We have time for one more question. How about right over there?
Hello. Hi. Thank you so much for your talk today. My name is Bonnie Koo. I'm a second-year public health MBA student. And I believe as part of your work, you must be making a lot of decisions. So I'm curious about decision-making. I'm always a little bit concerned about consequences of it. And so what's your kind of difficult decision you're having to make, maybe today or yesterday, and how are you approaching it?
Decision-making. I don't know that I will tell. part of me wants to answer your question by, I spent 25 years as a venture capitalist by just talking about the power of a partnership. And one of the things that comes up if you study group dynamics is, first of all, like you need the group to be somewhat like in the 4 to 7 range. Like above 7, it's very difficult for groups to make decisions. People start to, they feel a need to stand out. So if like the first 5 people agree, they're just going to take the other side for the sport of it, and you get a lot of cacophony. And then something that's similar to what you said earlier, people that study group dynamics, if you're in a small, highly trusted partnership, everyone knows the other partner's weaknesses. And so when a decision's being made, you know who to listen to and who not to listen to, because you have a better filter for that than they would for themselves. And so in venture capital, like you're making very big consequential decisions in very short time windows. You meet an entrepreneur, it's a competitive situation. They might take the other firm's money. You've got to get to yes or no very quickly. So I think it's an interesting test for kind of high pressure decision making. And I think that kind of small group is the best thing. Like I would not have wanted to be a venture capitalist of one. Like I wouldn't have trusted my instincts enough.
Did you debrief bad decisions? Like if you made bad investments, was there a process?
Here's
for
the
that?
thing in venture, this is like super important. It's so asymmetric. So the biggest mistake I made in my career as a venture capitalist, I had Larry and Sergey present to my partnership when there were 25 employees at Google, and we failed to lay chase. So nothing else. The amount of money we missed out on by getting to know was so like wild compared to like getting to a yes on a bad deal costs you 1 times your money. And so my partner Bruce came up with this phrase, what could go right? And so no, we don't reverse analyze. Well, the only ones we spend time on are the ones that should have been yes that were no. We analyze those ad nauseum. Does that make sense?
Well, thank you so much. Let's give our panelists a big round of applause. And a special thank you to David Epstein. Thank you so much for your excellent questions. Bill, you're hanging out. All right. Thank you so much. Well, Bill's staying with us for the next part of the panel, and joining him on stage is the legendary entrepreneur and investor, Mark Cuban. Yeah. Mark has always been an entrepreneur. From selling and trading baseball cards, selling garbage bags and magazines door to door, to starting a business, buying and selling stamps at age 16, there have been few years in his life where he wasn't starting or running a business. After graduating from Indiana University, Mark moved to Dallas and founded Micro Solutions. The company became a national leader in systems integration and custom applications with nearly $36 million in sales, before being sold to CompuServe in 1990. He co-founded AudioNet.com, which became Broadcast.com, going public in July 1998 with the largest first-day jump in share valuation in the history of the stock market. It was sold to Yahoo for $5.7 billion. Afterward, Mark purchased the Dallas Mavericks, leading them to the 2011 World Championship.
It wasn't me. I didn't have a jump shot. No.
See, that's what you get the applause on, Mark, right there. The Dallas Mavericks. He later became a shark on ABC's Emmy Award-winning business show Shark Tank, investing millions of dollars in hundreds of small businesses. He also co-founded HDNet, Landmark Theaters, 2929 Productions, Magnolia Pictures, and CostPlusDrugs.com, which is his latest venture and one I know we'll hear a lot about today. Bill and Mark will discuss an important question. Can entrepreneurs disrupt and innovate in healthcare? Bill, let me turn the floor over to you to begin the conversation.
Thank you. I oddly was fortunate enough to meet Mark way back in that storyline after this sale to CompuServe. It was about 93, 94.
Yep, early 90s.
Yeah, so 30 years ago. So it's been insane to watch what you've accomplished.
And you introduced me to Travis, right? His first company,
Yes.
right, which led to my biggest loss. He didn't invest in Google. I missed out on Uber. Bill literally introduced me to Travis, who had a company before Uber, and I helped him sell that company. Then he came to me with Uber, and like Bill with Google, I waited and over-negotiated, and Travis just walked, and the rest is history.
Yes. Well, you did okay.
Well, so have you. Yeah, so have you.
So since I delayed to talk about healthcare innovation, let's jump right in.
Sure.
So you've done all those things he just listed. You could just sail off and live on an island, or you could just watch the Mavericks. And you made this decision to lean, not in a little bit, lean in a lot with cost plus drugs. What's the origin story? How did this come to be something Mark Cuban is and it looks like you're leaving other things to do
this, yeah. And so back in 2017, 16, when the Republicans were talking about replacing the ACA, living in Texas, I had people come to me, well, you come up with an idea to replace it. And so I started digging into healthcare. Like you talked about learning ancillary things that don't have an immediate benefit. I'm just insanely curious when it comes to business type stuff. And so I started digging in. Then I got a cold email from a Dr. Alex Oshmayansky. And he said that he wanted to build a compounding pharmacy that manufactured injectable specialty generics that are on short supply, which included pediatric cancer drugs, Pitocin, all these drugs that you would never think would go on short supply, particularly since they're generic. And I was like, that's really interesting, but that's not big enough. And it was right around the time the farmer bro, Martin Shkreli, was going to jail. And I'm like, what the hell happened here? And so Alex and I started talking, and it became really obvious to me that the missing link in healthcare, but in pharmaceuticals in particular, was transparency. So I was like, okay, we can work on manufacturing, but as part of this, I want to create a website effectively that is completely transparent so that we can start with generics and put a website, and we got costplusdrugs.com. But what we're going to do that's completely different is we're going to tell you our cost. We're going to tell you our markup, and as a result, our prices are going to be cheaper, but more importantly, the biggest missing component on the financial side of healthcare is trust. And I'm a big believer that trust equals transparency divided by self-interest. And our transparency was who else shows you their cost. And our self-interest was our markup is only 15%, so you could trust us. And that was January 19th of 2022. We had 111 drugs, and we've since helped millions of people in less than 4 years. And so that was how it started, from just a cold email.
Yeah. And why is this personally motivating, such that Mark Cuban's spending the majority of his time on it?
Does anybody here like the way healthcare is run? No, I mean, it was like, as an entrepreneur, you look for the obvious things where there's an opportunity. And then you look for the complexity of it all and whether you think you can have an impact. And usually when you're selling something new or doing something new as an entrepreneur or trying to disrupt something, you're going in and you're saying, it's going to cost you a little bit more, but there's a long-term benefit that's going to pay off. With this, with Cost Plus and changing healthcare, starting with pharmaceuticals, it's the exact opposite. I walk into CEOs and say, this is going to cost you less and you're going to get more benefit. You just have certain people within your organization that aren't comfortable yet. And I just have to get them comfortable, and that's what we've been doing.
So you're marketing primarily to self-insured employers?
Yep, to uninsured people for the retail site, Cost Plus Drugs. And then in order for us to grow our business, we have to get people away from the big PBMs and the big insurance companies eventually to be able to make their own buying decisions and do what's in the best interest of their members, their companies, their employees. And to do that, I have to educate CEOs and HR people and all the like. And so it's not just self-insured, but just everybody and anybody who will listen, because there is a path for everybody. Like I was just talking, John Hopkins, whoever does your employee benefits, you're getting ripped off. Your CEO needs to talk to me, right? Because literally, it is the easiest conversation I've ever had. Healthcare has been the easiest industry ever to disrupt because it's just be transparent and tell the truth.
Let me tell you something I've witnessed as a venture capitalist and see how this is different from your journey. I don't do a ton of healthcare, but there was a period where I looked at a lot of them. Having been involved in a Zillow or an Open Table or an Uber, I would think you could build a website for consumers that would be similar, like a marketplace. And what I found over years of talking to founders is a lot of well-intentioned founders would say they're getting into healthcare because they know it's broken. This is mostly on the digital side, not like products or drugs. And we definitely are going to go tilt against this. And they get in year 3 or year 4, and their revenues aren't as big as they want them to be. And they make a flip. They go from being outside to inside. And they attach themselves to the rock holds that are available, and they end up becoming a part of the problem. I've even seen some that are making it worse. Like
all the time.
So you understand?
For sure. I know exactly what you're saying, because you look at it. Here's a $5 trillion industry, right? And I can create change, and if I only get a smidgen, it becomes an arbitrage, right? And you can make money and change the game, but then you realize that the incumbents. You talked a lot about scale capture and regulatory capture.
Yeah.
When you have 3 companies effectively that just dominate, that set the rules and the economics, it's hard to work on the outside. And so that's why we had to go with Cost Plus. We went right to consumers. And we had to make it so that we can communicate to them very simply. Look at our prices. And the smartest thing we did, Bill, was publish a price list. Here we are almost 4 years later, and there is not one pharmacy or any organization that publishes a price list of their costs, whether it's medical or pharmacy. There's not one, right? And that was the smartest thing we did, because all I had to do was say, go to costplusdrugs.com, or if you're a company, email us here and we'll send you the price list, and you can do side-by-side comparisons. And so the first thing I did was with the Dallas Mavericks. And so when I was able to get the claims, because any of you who deal with pharmacy benefit managers know you can't get your claims unless you beg, borrow, and steal, right? It's nearly impossible. So I finally got our claims, and I did a comparison. How much did the Mavs spend on generic tablets, pills that cost $30 or more over a period of 18 months? $169,000. Of those drugs, and I only used the drugs that Cost Plus carried already. And we only had 111. I said, 169,000, how much would it cost if we bought from Cost Plus? $19,000. When you have that, it's easy to work on the outside, because people can't afford their medications. They have to ration their medications. We've heard the stories about people going to the pharmacy counter and, walking away in tears because they can't afford it. People dying because they can't get their medication. And so all I had to do, because I have a platform, was just go on podcasts, on TV shows, and just say, if you have a deductible and you are paying for a medication that we carry, compare the price of your deductible, your out-of-pocket, your co-insurance to our price, and there's a really good chance we'll save you money, particularly if it's a specialty generic.
Yeah.
And that's exactly what happened. And it's all been word of mouth and my big mouth. The total amount of money that we have spent on marketing and advertising, not a penny. But that allows us to keep our prices low.
Yep. Tell me, I know you could answer this question for 2 hours and 45 minutes. So try and find a way to put it into 5 minutes. But why do PBMs exist in America?
I'm going to give you a 30-second answer. There's no good reason. So I'll tell you exactly what happens. So they're all owned now by big insurance companies.
Yeah.
Big insurance companies control, across the biggest 3, let's say, insurance companies, hundreds of millions of lives. And if you're a big insurance company who's a public company trying to hit your numbers, and you think, we have these hundreds of millions of lives, if we can create a new entity that can leverage those lives and say to brand manufacturers and even generic manufacturers, if you want your medications to be available as part of the plans that we're selling to these hundreds of millions of people, we're going to invent these things called pharmacy benefit managers effectively, where we're going to buy them, and you have to pay us to get access to those lives. And so pharmacy benefit managers exist only to auction off access to the lives of that they control or that their parent insurance company controls. That's the only reason they exist.
And they don't exist in other countries around.
No, when people talk about MFN, right, the difference between our prices here for brand medications versus other countries,
Right.
the difference, 80% give or take of the difference, is the cost that the PBMs introduce into the cost of the medication.
And if people don't know, MFN stands for Most Favored Nation.
Yeah.
So there's been some argument. Trump's made the argument that we should have a policy that no drug should cost more, offshore than it does on. And there are many that cost way cheaper offshore.
Way cheaper, yeah.
than-
And we're the only country that uses PBMs.
Do you think PBM should go away? Do you think there should be PBM light? Like, what's the?
Well, you got to ask, what are they trying to do,
Yeah.
right? And they say that they protect patients by negotiating better prices. And what I respond to, and I'm curious to hear what happens in the next session, right? When I respond to that, I said, just look at your deductible phase. So if you have an ACA Silver plan and you have what's the typical deductible, which is $4,500, $5,000, right? And let's just say you need an anticoagulant like Eliquis. The list price, not the net price, the list price of Eliquis is about $600. So any ACA plan holder, before the subsidies or after without subsidies, when you go and you're within that $4,000 deductible, for that first month, you're paying the full list price.
Paying list, and you're going to max
List
out
price.
for sure.
Right. You're paying list price until you max out your deductible, right?
Yeah.
What the fuck are the PBMs doing if they're so good at negotiating prices, right? Why is it that the patient who needs to save money at the most critical time
Right.
is getting retail price? If a PBM can't negotiate better than retail price,
And high deductible plans are on the rise as a
right,
percentage
because
of
people
all
can't
plans.
afford it,
Yeah,
right?
yeah.
And so, I give a lot of talks to HR managers, benefit managers, and I always ask the question. Raise your hand if you know one thing that your PBM does that is so unique and differentiated that you can't live without it. No one's ever raised their hand. So it's more out of habit, right? It's just like, why do people keep on doing this, using the same companies they've always used,
Yeah.
even though there's a better, cheaper, faster alternative? Because it's the path of least resistance.
Well, I do think another problem, I mean, you and I have talked about this indirectly on Twitter, but we're the only country in the G20 where the majority of people get health care through their employer.
Right.
And that employer is not an expert in this field in any way, shape,
Oh, yeah, and the insurance companies take advantage of that, as do
Right.
the PBMs. There's definitely an information asymmetry,
Yeah.
right? And so what happens in this country is there's market dominance in two sides of the equation. Market dominance from the big hospital systems that control some big market share, and so they get to insert their influence on the pricing, and then market dominance by the insurance carriers / PBM that they own. And they battle it out, and the patient is the loser in all of it because nobody puts patient first. You don't hear any insurance company saying, yeah, we decided we're going to lower our earnings and ask for a higher PE from our investors so we can serve patients less expensively.
Yeah.
And you won't either. And now these companies have gotten so big, multi-$100 billion revenue companies, top 3, 5, 7 in the Fortune 500, that it's impossible to stop them.
What do you think is the right endpoint for drug purchasing for insured people in the U.S.? Should the PBMs be taken out? Should there be a PBM light? Can cost plus drugs do 100% of it eventually?
Yeah, it's easy to do,
Yeah,
right? So we don't carry every drug.
right.
There's a lot of brands we want to carry, but we can't. The question is, why can't we? Because every single one of those brand manufacturers that we go to and say, we'd like to carry your medication, we'll only mark it up 15%. And that way, it's going to be cheaper, particularly during the deductible phase, for all the patients that want to use your medication. And they're like, always, 100% of the time, we'd love to. But these big PBMs that control hundreds of millions of lives, they've effectively told us, if we do it, they will diminish our entire portfolio of drugs on their formulary. And if you're not in tier 1 and all of a sudden you move down to tier 5, that could cost you tens, hundreds, billions of dollars across a portfolio. And so the PBMs have too much market power right now.
Yeah.
It is the ultimate in regulatory and scale capture. You got to break them up. And when I say PBMs, the big insurance companies, and maybe even a lot of the big hospital systems, sorry, Johns Hopkins, maybe you've got to break them up.
Could they just pass a simple law that you can't charge a different price pre-deductible?
I mean, could you just work at net price?
Yeah.
What the simple law would be, PBMs can't control formularies.
Yeah.
You have to disaggregate formularies from PBMs. They will lose all their leverage,
Right.
right?
Because they're custom pricing the way an algorithm.
There was one
an ad algorithm at a.
What? Not even
Yeah.
that. No, they literally auction off access to
Yeah.
their formulary.
Yeah.
There was one PBM that said to Lilly, and they had a bake-off between Lilly and Novo for GLP-1s. And Novo won. They literally kicked Lilly off of their formulary. It doesn't matter if maybe the Lilly GLP-1 option was better for patients. They got paid more.
So why are you able to get some drug manufacturers to work with you in light of that political pressure that
Well, the generics typically don't pay rebates, so that makes it easy, and we manufacture some of our own. But on the brand medications, the brands that we're currently getting are the ones about to go off patent within the next 2 years, or they already lost the bid to be on a formulary, so we're found money for them. And so that's what works, but literally, they know what we did to specialty generics in pricing. There's like a drug called imatinib, which is for leukemia. And when we got involved 4 years ago, if you just walked into a random pharmacy, big pharmacy, owned by a PBM, and you had to pay cash, it'd probably be $2,000. Now it's $34.50 plus $5 shipping. You know, and now they've had to respond to our pricing because, like, even the state of California told me that they used our price list to force one of the big PBMs to meet our prices. And so, you know, we can force change initially with generics, but for us to get to brands, one of the brand manufacturers, I said, how many lives covered do we have to have before you'll just add us? He said, 80 million. Now we're close to 22 million with our partners and everything, but 60 million is a long way to go.
Right.
So we can get there, but to benefit patients, to start to recalibrate the healthcare system, the economic side, you're going to have to break them up because the market is so inefficient. What's happening now, you've got these big insurance companies that are so big that almost all the acquisitions they make are considered immaterial, so nobody gets to review them or look at them, right? You've seen that game played 1,000 times, right?
Yes.
You just gross up, gross up, gross up. And so if you're a $400 billion company, a $1 billion acquisition, which could be incredibly important and impactful, no one's going to review it.
Is there, so you mentioned one potential regulatory change that could impact this, what's related to the formularies. Right. Are there other things you would recommend?
Disaggregate the formulary. 2 states, Texas and Tennessee, say that if you buy from Cost Plus Drugs and you send a receipt to your insurance company, they have to count it against your deductible. That effectively allows patients to shop, right? Because it gets to count.
And is that not true in the other 48 states?
Nope.
So they'll just declare it doesn't count because
we'll ignore it.
It didn't go through our system.
Correct. Now, if you are a self-insured employer, and this is part of the education I go through for them, you can include in the contract that you sign with the ASO, the people who manage it, right, that no matter where a patient buys it, it counts against their deductible, right? But nobody does, and they don't try to. Obviously, the insurance companies don't want you to do that. Other things that you can do.
Do you think more states will adopt this?
I hope so, but if it's a federal law, it becomes a lot easier.
Yes.
The other thing that they don't do is, as an example, every company, every individual is trying to make decisions about GLP-1s, right? Do you cover GLP-1s for your members, et cetera? If you're working with the big PBMs, you're not allowed to call up Lilly and say, hey, Lilly, let's work on a program to improve the wellness using your GLP-1s. Or Novo, let's do the same thing. Because as part of your contract, it says you can't talk to manufacturers. You can't talk to
Whose
them.
contract in this
The
country?
PBM contract.
With the insurer?
With the employer.
With the employer, okay.
Yeah. So for Benchmark or
Yeah.
Cost Plus Drugs, if we had an agreement with one of the big PBMs, they're going to say you cannot talk to the manufacturer.
And the ASO recommended you take this PBM
This
deal.
right? Consultants recommend you do it. Brokers recommend you do
Right.
it. You know, there's just, like you talked about the entrepreneurs who couldn't get, who ended up going inside the system.
Yeah.
It's hard.
Yeah, it's hard.
It's very hard.
Why, are the ASOs interested in the patient's well-being and cost or not? And why?
Are the insurance companies that
They run them, right?
they run the ASOs?
Yeah. Does any
No.
non-insurance, is there any radically disruptive ASO alternative?
Oh yeah. I mean, for my little companies, so if you look at healthcare from the provider.
These are people that administer your plan for a self-insured.
Self-insured company, right. But if you look at the economics, right, the economics of the pharmacy side are the worst I've ever seen in the history of bad. And so here's how it works. The manufacturer, brand manufacturers in particular, brand manufacturer sells to a wholesaler. There's three big ones that dominate more than 90% of the market. Now, if, using Eloquist's example, if the retail price, what's known as WAC, which is the wholesale acquisition cost, but if it's the retail price, is $600. You know what the wholesaler pays the brand manufacturer for that $600 drug? $600. And then if they pay the $600 within a couple of weeks, they get 2.5% back. And then if they send a report to them saying, we paid you the drug, you paid for it, and we're doing what we're supposed to, another 2.5%. So they make about 5%, $30. By making those drugs all work from the retail price, it distorts everything downstream. And it makes it really difficult to get to the net price, which is exactly what the insurance companies want, right? It's exactly what the PBMs want. It's exactly what the patients don't want. And so that's one way where it goes bad, right? And then the other side is on the healthcare side, if you go to the hospital or a doctor's appointment and you have an ACA Silver plan, or let's just say you have your corporate plan. You work for Johns Hopkins and you have great corporate insurance and you have a $2,500 deductible, right? Is that high, low? Low? Oh, you guys are fucked. Right? And so $4,000 deductible. Right? And you go to the hospital. You can't go to someone else in network. Let's not use Johns Hopkins. And you go there and you have a $4,000 deductible and it's $1,500. And you're one of the 40% of people in this country that don't have $400 to your name, let alone $1,500. Now, all of a sudden, you've put that provider, the hospital, into a bad spot because either they put you through the emergency room, right? Or they want to service you because you're in network for them, but you can't afford the out-of-pocket. So now you've turned them into a subprime lender, right? Because you're going to loan them money just to be able to get into the deductible. And all the stories you hear about people going through bankruptcy because of medical debt, a big chunk of that is because they can't even afford their deductible. But wait, there's more, right? Because now you have something and they found something and you have to get a pre-authorization. Now, the bad side about pre-authorizations from the provider perspective isn't that they're checking to see if you really need it. It's just they're going to delay you just for sport, right? Because they get the time value of money.
Correct.
And so now, in addition to that, the doctors have to waste their time convincing. The HR people at the company have to waste their time dealing with the employee whose kid's sick and they can't come to work, right? And so that's a problem. And then you have, I won't go through all the specific deal, but effectively, you create a situation where the hospitals have to have all this oh, wait, I'll give you one other. So let's just say for whatever it is that you needed to go to the hospital for that and it's $3,500, they've already negotiated a price, let's just say for that. Let's just say it's an arm setting with a complicated, whatever. And the cost, they've negotiated a price with the big insurance company, that's the ASO that they're working with, and that price that they've negotiated is $3,500. You would think the insurance company that negotiated the $3,500 price would pay them $3,500, right?
Right.
You'd be wrong.
Okay. What happens?
They'll underpay them, right? And then they'll say, come sue me. Or you have to do all the paperwork. Or that I was too far to the left when you dotted it. We want our I's dotted to the right. And they'll make up an excuse.
This is the insurance company refusing to
pay right.
the provider.
And that's why, like, John Hopkins gets into it with United Healthcare and a variety of other reasons, right? And in-network, out-of-network, and all these games. So all these things happen that cost providers a ton of capital, right? And a ton of time and overhead, and that's part of the reason we hear about all the administrative costs, right?
Right. There's surveys that say 40% of
20, 30, 40%,
Right.
whatever it is. So what
it's
we said,
bureaucratic paperwork,
a
pencil
nightmare,
shoving.
a
Yes.
nightmare. And so what we said, okay, for my companies, we're going to direct contract. And so we started going.
This is going all the way back to the ASO question.
Right. Yes.
Okay. All right.
Because rather than using, because I self-insured
Right.
and used an ASO, and so as I looked at all this and learned, you talk about peer learning, I would just go and mentoring, I would just go around to all these CEOs, all these CFOs of health organizations, and they're not choir boys or women by a long shot, but from this perspective. And I said, well, what if I just paid you cash up front with no prior authorizations? Would you give me a discount? Yeah. I'm like, okay, give me a discount. And so
who are you talking to? Who are you?
We're talking to big hospital networks.
That are in your region for
Right, yeah, or national, whatever it may be, right? We're talking to, ambulatory surgery centers.
Yep.
Anybody that wanted to work with us
Yep.
and give us a good price, let's go. But the one thing we did that's different, we said to be part of this deal where we pay you cash the minute it's done, there's no pre-authorizations, the price is the price, we cover all the deductibles so the patient, the employee, member you don't have to deal with the deductibles, become a subprime lender. I want one thing other than price. I want to be able to publish the contract so that other people can copy what we're doing. So we just launched, it's still soft launch, but if you go to costpluswellness.com, you'll see our contracts. And as people have started slowly but surely going there, the self-insured companies that are working with this ASOs are saying, look at this contract. Just like at Cost Plus, they were saying, look at this price.
Yes.
Why are we not getting this, and this?
So what I'm hearing, just for clarification, is you've taken over the role of the ASO inside of your own company and created a bootstrap
And it's easy.
healthcare program for a self-insured employer, and then you've documented it so that
others can replicate it.
Yes.
Right. And we have a third-party administrator, a TPA that we work with that does the claims processing.
Yeah.
Right. And we have a healthcare CFO, CEO, if you will, that we have a saying: if you can schedule it, you can negotiate it, and that's all they do. They make sure that the hospitals don't go off course from our contracts, and that if something's more complicated, we remind them that we'll work with you because that's the patient's chosen doctor, but we also tell the patient, the member, that if you let us negotiate, we're going to save you and the plan money over the long haul. And so we do that, and it's saving us a lot of money.
So, how does it work with a employee that wants to go outside of because you've created a narrow network?
Yeah, unless it's actually an open network, right? But it's narrow as of now,
right?
But if it's somebody, a specialist, whatever, we'll call them, and we'll say the exact same thing. Do you want to get paid cash up front, no PA? Give us a better price. Great. If not, none of our deals are exclusive, so we can negotiate with somebody else. And if the member, employee, family member just adamantly has to go to this other, then we'll make them pay a deductible as part of it.
Does Cost Plus Drugs aim to be in this business, to move beyond?
I don't want it to be a business. I want it to be open source.
Okay.
I just want to fuck them up.
Yeah. Yeah.
Yeah, seriously. I mean, the feeling. It's not about the next dollar, right? It's more what kind of impact can you have.
But, this could be the type of program an open source administrator like the Linux Foundation could run.
Well, exactly, right.
Theoretically.
Yeah. Yep. Where, we'll keep on publishing all these contracts and all these offerings, and we'll see where it takes us.
That's
but
awesome.
when you improve things, business opportunities open up.
That's great. So, pharma, according to the AI that I talked to, is about 10% of U.S. healthcare
Right.
spend.
Right.
So you're in and around this all day. What are the problems and solutions outside of pharma that you feel passionate about or have identified?
Just in terms of regular healthcare?
Yeah, the other 90%.
Yeah, well, it's growing on pharma, but yeah, just what I was talking about, right? Because when you look at the dynamics between the big health systems and the insurance companies, it's a battle of the titans. And it's like watching, Godzilla versus, whatever, and they're stepping on people.
Right.
And when they're battling. And so what we're trying to do is bring transparency there as well and help people understand.
Through the program you just talked about.
Right, and just discussions like this, right? Helping people understand how the economics and the flow of cash works, because that drives everything, right? And so we'll get there. But I'll give you another example. Like those PBMs. You would think, even as convoluted and upside down as buying the cash flow of medications are through wholesalers, right? You would think if you're a pharmacy and you buy a drug like Eliquis or any brand drug from that wholesaler, you'd make a little bit of money. You would be wrong. Almost all the independent pharmacies or medium-sized pharmacies, when they get reimbursed, when any of you take your Johns Hopkins prescription for a brand into a local pharmacy, they don't get their money back. Because of the deal your CEO signed. Your CEO hates independent pharmacies. And that's what I tell him. But the same thing that the PBMs are doing to the independent pharmacies, the big insurance companies are doing to independent physicians.
Yes.
They're pushing down and making it so difficult for them to get paid for the work that they're doing that they're going out of business or being forced to sell. And you're seeing these
forced to sell largely to these large university healthcare systems who are growing.
And who just do an arbitrage, right, on location.
Yes.
Right? Your clinic or your practice was in the 4th floor of our building, but now that we bought you, we'll pay you less, but we'll charge a whole lot more.
Yes.
And so what I've been
on our labs and our pharmacy.
Correct.
And our image.
Correct, right? So it's completely an arbitrage and gaming the system. So what I'm doing, you talked about, learning from peers. So I go online, I go on LinkedIn, that's how I make, I go on Twitter, right, X, and I just tear up everybody that I can. And a lot of people disagree with me, right? But that's where I learn.
Right.
Right? Where the things that I got wrong, okay, I got it wrong. I'm happy to be corrected, right? I want to learn what comes next.
Bill, I'm so sorry. I got to stop you there.
Yeah.
Let's give these folks a big hand. Time goes fast when you're having fun.
Yep.
We have some time for Q&A. Let's start right over here.
Hi, thank you so much for being here. My name's Talia Shalhoub. I'm a first-year MBA student, and I'm a senior program manager. I can really tell the passion that you both have for this, so really appreciate that. I think we can agree that there are opportunities in the industry. Now, not everyone would agree, so what advice would you give to entrepreneurs who want to disrupt this space, who might have a problem, a solution, but they don't have the platform or the capital to get there? What can we do? Thank you.
I mean, you got to start somewhere. And depending on what your solution is, you can't just assume that everybody's going to switch to you. I think the mistake a lot of entrepreneurs make in this space is they think, well, if I go to companies, I only get $1 per employee per month, then it's all going to work. But you're one of 100 that are pitching to the companies. And so you've got to find a smaller company, typically, that is more willing to listen because you can bring it straight to the CEO and get them on board. And if you can do that, then and get results, what you'll find is results lead to more customers. But you've got to find an opportunity where you can introduce the results and people will help guide you to those results, and then you can talk about it and get more customers.
I think there's a lot of things you got to be careful about. So I used to describe it as instead of there just being gravity, there's like 5 different forces that you didn't know existed. And like a common mistake I see is people think consumers are shoppers. hopefully they will be one day, but they're not there yet. And I don't know if HSAs or whatever, but like there's a path to get them there, but they're not mentally shopping yet. And then another one I saw constantly is entrepreneurs think insurance companies want to save money on costs. Like I see that one over and over and over again,
Fact.
and that is not something they're interested in. So it's a tough game. Like it's God bless.
Thank you. How about right over here, please?
Thank you. Hi, Marianne Mass. I'm a practicing pediatrician. We know one another a little from X. Thank you for responding and sharing. I co-founded a physician-patient advocacy organization, and I like to write a little bit, so that's who I am. You talked a little bit about the distributors, which are equally as horizontally consolidated as the PBMs and beginning to become frighteningly vertically integrated. Is there room to move on the distributors? They do serve the purpose of moving drugs around the country, and that's a good purpose. The PBMs,
I think if you get them to go net pricing somehow, that changes the game for them. But you're right. Thank you very much. But you're right. They are becoming as vertically integrated as they can be to control their own destinies. So they're buying oncology clinics and everything else and then they'll make sure that the flow of dollars for go to them, and then with enough lives covered in those clinics, they can then go to the brand manufacturer or specialty manufacturers for those drugs and say, you got to work with us, and you've got to pay us X, Y, Z. We have got to get the Department of Justice and FTC looking at every single deal regardless of size, because the whole immaterial scam is just that, a scam.
Thank you. How about up here?
Hi, thank you guys so much for your time today. My name is Eris Hansen-Cooper, and I'm the founder and CEO of Genwell, where we are building the Credible TikTok meets Mayo Clinic exclusively for credible women's health and social commerce. My question is that after 10 years of building in digital health, from Optum and UHC to then trying to rebel at startups, what I've noticed is that there is a big difference between the venture capital size return expectation and actually lowering costs in consumer health. Wondering if you guys can speak to how you find your role as venture capitalists and the participation in the healthcare industry directly.
You're the VC.
Yeah, you've given out a lot of angel checks.
Yeah.
Look, I think it's a real issue. I mean, I already told you that the common journey I've seen is a company gets in thinking they're going to be disrupted, needs to monetize, and then the next thing you know, they're negotiating $5 PPM with a self-insured employer or trying to get on the claim reimbursement schedule and they start driving it up. I think it's very, very hard. I wouldn't. The question came up earlier about purpose. Like I wouldn't go into this with rose-colored glasses. Like I would go in like determined that you're going to make change, but it's just so hard. I don't want to talk anyone out of it. I think we need to fix the problem. So, and personally, like I wouldn't blame VCs. Like I get in, do a deal, the founders are just as interested in making money as well. Like it's just where things go. But being outside is hard. When I say outside, like you're trying to price around the system, you're trying to cash pay. To a certain extent, Hims and Hers and Roe kind of live outside the system. 23andMe tried, and it was very hard.
But Hims and Hers are a great marketing company.
Yeah.
Right, that's what they do, yeah.
Yeah, and things like LASIK, like things that are cash pay, those industries are highly competitive. You end up with price, like they go way down, like innovation works. And in the way our system's structured right now, that's why entrepreneurs come in thinking you can do the same thing in healthcare, and it just doesn't work. I would love for it to work.
Yep. Well, folks, we'll have to leave it there. Let's give Mark and Bill a big hand.
Thank you. Good to see you.
Well, we have an exciting discussion coming up next, but before we go on, we'll take a very quick 5-minute commercial break. Please stay close. We'll start right on time, and you won't want to miss the final session. See you soon. All right, folks, let's grab our seats. Thank you so much. Fantastic. Well, for our final session, let's welcome back out Mark Cuban and Dr. Patrick Conway. Well, let me introduce, you all know Mark, but let me introduce Dr. Patrick Conway. Dr. Conway is CEO of Optum, a $250 billion health services organization serving over, I guess Mark's leaving. That was quick. Serving over 127 million people. Optum includes three main business units: Optum Health, with nearly 90,000 clinicians delivering care across multiple settings; Optum Rx, serving over 62 million people with pharmacy services; and Optum Insight, a data and technology business supporting health systems, payers, and life sciences. Previously, Dr. Conway led Optum Rx and Care Solutions, serving patients across acute, post-acute, home, mental, and specialty care. He also served as president and CEO of Blue Cross and Blue Shield of North Carolina, and deputy administrator for innovation and quality at the Centers for Medicare and Medicaid Services. A practicing pediatric hospitalist, Dr. Conway earned his MD from Baylor College of Medicine and an MS in clinical epidemiology from the University of Pennsylvania. Mark and Patrick will share their perspectives on payment and delivery innovation in healthcare. And moderating the discussion will be my amazing colleague, Professor G. Bai. Let me just say one thing about G. I'll keep it short, but she's just fantastic. G's a professor of accounting at the Johns Hopkins Carey Business School and a professor of health policy and management at the Johns Hopkins Bloomberg School of Public Health. She asked me to keep it short, so I'll skip the fact that she's testified before the House Ways and Means Committee and the Senate Help Committee. She's written extensively, including in academic journals, and I'll just go here to the end where her work's been widely featured in the media and also used in government regulations and congressional testimonies. Professor Bai has received the Johns Hopkins Alumni Association Excellence in Teaching Award, and we're so thrilled to have you with us today. Professor Bai, please.
Thank you very much, Stephen. What an honor and privilege for me to moderate this amazing session. It's truly a blessing and honor for us to have you two to join us. So let's straight dive in. We already know Mark is no fan of PBM, right? That's why I want to give the floor first to Dr. Conway. Talk about if there's any misconception about the PBMs.
Yeah, so I look forward to this, especially after, I'm just a small-town pediatrician from Texas. Worked this weekend in the hospital, which we can come back to. Look, first, Optum Rx, actually, the PBM is about half the business, but the other half is pharmacy services. So think Genoa, which I was just at, integrated mental and behavioral health care for people with complex healthcare needs. Two, and I think we'll hit on this more, it's a clinically driven organization. So if you think about the mission, it's right medicine, right patient, right time, right dose, affordably, and we'll break down those various components. Three, comprehensive. So people have diverse healthcare needs, from generics to brands, from cancer to asthma to whatever their conditions are, and we tackle that holistically with our clients. We'll get into the savings numbers. Optum Rx last year negotiated over $50 billion of discounts or rebates on behalf of our customers. We have over 5,000 employers, health plans, unions, governments that have elected to use our services. Pharma companies, by the way, use PBMs. And actually, Optum Rx is the only large organization that announced 100% rebate pass-through to our clients across the board. And I'm sure we'll talk more about that. And that's because we want the list prices of medications to go down. On clinically, before you interrupt me, I know you're going to interrupt me a lot, and I look forward to it. As a pediatrician, I'm very polite, so I will not interrupt you back. But a story that I will share with you, because it gets to the heart of the affordability issue. When I was much earlier in my clinical career, we discharged a patient with an infection. By the way, when you have an infection, you need medicine right then, not via mail order, which we do as well. And that patient went home and she came back, 2-year-old. I felt horrible. I asked the mom what happened. Well, I went to the pharmacy and the copay was $200, and I didn't have $200. So I was going around trying to get $200, and my kid got very sick and got readmitted. It was an early lesson that if you don't have affordable medicine, bad things can happen to people. And it's why, you know, it's one of the many reasons I still would do the work today. This weekend I took care of a kid with asthma. Same core issue, controller medicine, which we know can prevent asthma. Good evidence, we can prevent asthma. I've got 2 kids with asthma. I'm a pediatrician. I had asthma. If you get well-controlled adherent medications, they don't get admitted to the hospital. When we fail to do that as a system, which I think is where we should try to focus, then children or adults get admitted, costs go up, quality is uneven. So that's some of the core things we're doing. I'm sure we'll get into a lot more detail.
Yeah, so I'd be curious, what did you think about the young man, 22-year-old, who couldn't get his Advair at the pharmacy, who was a United patient?
Yeah, so a couple things. So obviously at the pharmacy counter, I was not there at the pharmacy counter, but let me tell you how the process is supposed
Well, just so you know, there was a 22-year-old kid.
Familiar with the story?
Yeah, of course, yeah. I know you are, but I don't know that they are.
Yeah, so at the pharmacy counter, there were multiple low-cost generics available, including to that person. I'm looking at our head legal counsel. This one also has a legal case.
You brought your head legal counsel here?
For Optum.
Where is he? Where is she?
She's over that way. So
The one with the gun and the badge?
but this is actually, look, the case, and let's zoom out from that case, because it, for any patient, their ability to get a medicine and what should occur in that case and other cases, and there were low-cost generics available, that should be communicated to the patient. Transparency, choice, affordability. That patient should be able to fill the medicine.
But a kid died. There was a kid that went, he was a United Healthcare customer, correct? I had a UNH plan, and Optum Pharmacy, or
Yes.
Optum PBM, and went to the pharmacy and couldn't get his Advair. And when he couldn't get it, left, died.
So
I'll let you fill in the story.
Yeah, so look, and I would say the following. In that case and in other cases, and once again, none of us were at the pharmacy counter, and there's now a legal investigation about what happened in that pharmacy that day. I can tell you the process, and we've looked at this case and other cases. We've got a critical drug affordability program, of which asthma is one of the conditions. The reason we did that program, the copays are $0 or $5, is because there is no moral hazard around things like asthma, diabetes, et cetera. You want people to get their medicine. So we now have well over 150 medicines with $0, $5 copays, because you want those patients to be able to get their medicines to prevent hospitalizations.
Advair is like $20, isn't it?
So on critical drug affordability, you have controller meds, of which Advair is one.
Well, then let me ask it a different way, different situation. Someone in their deductible phase for a brand medication.
Yeah, so the critical drug affordability, so we work with clients, employers, others that, as you alluded to, have different benefit designs that they choose. On critical drug affordability, our suggested benefit design for these 150 plus medications is $0, $5 copay. The reason we started that program, and you're hitting on a core issue, and there are some things we probably are going to agree on. I do agree on lower cost drugs. I do agree on transparency. I do agree on choice. Those drugs should be a lower copay because you want people, whether it's diabetes,
Yeah, but not the point, right? Of course you want it as inexpensive as possible, but these are choices that you guys are making, and one of them is to work at a gross price during the deductible phase, WAC price, as opposed to a net price. Knowing that if a drug is priced at net during the deductible phase, by definition, it's more affordable, correct?
That's
Let me jump in. Let me explain what Mark just mentioned. There's a gross to net price bubble because of the rebates. So the PBMs get manufacturer rebates. The rebates becomes the difference between the gross price and net price. That's what Mark's talking about. The patient's cost sharing is based on the gross price, not the post-rebate net price.
and to be
Why is that?
And to be clear on facts, just because
Feel free. Go
Facts do
ahead. Facts
matter.
matter.
So benefit design. So we serve over 5,000.
No, now you're changing the subject.
No, not
Right.
change the subject.
We
We serve.
why do you charge full whack price to somebody during the deductible phase? And
So
are you saying that it's the choice of the employer and you just let it happen even though it's your customer, or?
Let me describe the system. and
Okay,
then I'll
go ahead,
answer your
your system.
question. So you have benefit designs. We serve over 5,000 unions, governments, employers, payers, et cetera. They have benefit designs that they put in place on co-pays, deductibles, et cetera. We do work with them on those benefit designs. As I said, lower deductibles, co-pays, $0 to $5 range. In terms of gross to net, we are negotiating a net price on behalf of our customers. We, Optum RX, have also said, which is one of the things you pointed out for others, that the customer should never pay more than that net price. So we put that into our system, 100% of time, 100% of claims. Checked it again before this session because I knew.
Does that include the rebate GPOs?
Yes, so all the way through the GPO.
So
to the net price.
MSR makes no money anymore and they're of no use any longer and you're going to close them.
So the negotiation from the GPO, of which, so there's group purchasing organizations for a number of the pharmacy organizations. Ours is called MSR. So for our rebates negotiated from our group purchasing organization, which has saved the people we serve over $50 billion over the past year, those are passed through to our clients, which are employers, unions.
So
health
effectively
plans.
MSR, sorry to interrupt, but effectively MSR is doing the negotiation. You created a subsidiary that's based where?
It's actually based in Delaware. You think it's based in Ireland, but it's not. It's legally in Delaware.
Okay, so you have, but the people are based where?
People are in the U.S. and some of them are in Ireland.
Some of them are in Ireland. So you created a company, despite the fact that you were part of a $400 billion organization that is designed to negotiate rebates primarily with brand manufacturers. And now you're saying that that company negotiates, but they don't keep any of the money. They used to do that, but they'll no longer do that. Is that what you're saying?
So group purchasing organizations are broader than just the pharmacy value chain, as you know. So you pool negotiating power to get lower prices on behalf of your customers. That's true in healthcare and outside of healthcare. And yes, what I'm saying is we announced very clearly 100% rebate pass-through to our clients.
Starting when?
We announced it beginning of this year. And is that your question?
Well, no, not
No,
when
it's
you
starting
announced
now.
it. When
Announced
did
this
the
year.
program?
So you have contracts on 3 to 4 year cycles. Every single contract that comes up, we move to that cycle. We've already moved over 95% of the contracts. You obviously don't break a contract with another private sector entity, but we're negotiating 100% rebate pass-through today.
I wouldn't know, obviously, because nobody's allowed to publish those contracts. And so all the different employers can't really compare notes. Why do you prevent them from being published?
So I will answer, but you feel this is like you're moderating me.
No, I'm just I'm trying not to interrupt, but I'm hearing stuff, that doesn't jive with the reality that I've seen. But if I'm missing something,
Actually, look, to be clear, I can speak for Optum RX. I'm not going to speak for others in the industry. I think one of the reasons we're growing faster than others in the industry, which is publicly known by a good margin, is for our clients. So last year we had over 98% renewal rates. We had a satisfaction rate 90+% when you look at our client base. On new clients, we had an NPS of 100. I haven't seen an NPS of 100 almost in anything. So the actual people we're providing services to, employers, unions, governments, et cetera, including on transparency, choice, affordability, and we provide them that transparency.
So give me a name of one of your biggest customers so I can call them and see if they love you guys.
You should feel free to call any of our customers.
I want to know who they are, right?
So one thing I want to mention is nobody's forcing employers to choose PBMs, right? If employers don't like the contract, why cannot employers force the PBM to do the right thing or change to another PBM?
Well, they're starting to, and that's why I go out and talk to CEOs. And that's why there are 25, 30 truly pass-through PBMs that are taking business. Now, when they say 98%, I don't know if it's of accounts, right? Maybe, or of lives covered, don't know. More power to you, whichever way. But the reality is there's an information asymmetry. So when I go talk to CEOs, I have a list of things that I ask them. Like one of the first things is, do let's just say it's 10,000 lives, 15,000 lives. Do you control all your claims? Do you get access to all your claims?
Do you agree? Many employers are not doing a good job.
Oh, no.
They love the quarter rebates, though. That's what I heard. You want them to
But
change.
you can't have it both ways. You can't say we just pass them through and they love rebates, because if all rebates are passed through, what's the point of rebates?
Well, they use those to fund. I mean, the employers use those either at the point of sale to lower cost, or they use them for their overall premiums or deductibles.
Now, do you realize what you're saying? So which do you suggest an employer should use?
Actually, we suggest you do it at point of sale, but it is their choice. As an employer, as a health plan.
But then why have rebates at all, right? Why not change the whole system? This is what you're suggesting, right? If you're taking all the rebates.
No, let's play that through.
Okay, go ahead.
If you had no rebates today, if you
Right.
snap that wand immediately,
Right.
which, by the way, some states are debating, you will transfer hundreds of billions of dollars, because it's $50 billion just on RX, from employers, health plans, et cetera, to pharma companies. So if you want a
what you're saying
system-
is, to Guy's point, those employers are smart enough to let their sickest employees create those rebates, but they're not smart enough to work with their own GPOs that they create. They couldn't create their own rebate GPO to negotiate with brand
If you imagine let's 2 parts, and then feel free to direct
Jump
us
in.
wherever. 2 parts. If you imagine a 50 employer group,
Right.
and you imagine they're going to negotiate a similar set of deals with all the pharmaceutical companies in America, that won't occur.
No, what they'll do is, I'll tell you exactly what they'll do. What they'll do, once Cost Plus Drugs is allowed to work with those big brands, because you guys are telling them they can't, and you can address that, feel free.
That's all
Because
right.
what we'll do is we'll negotiate, like we've done with specialty generics, like we've done with biosimilars, and we'll publish our price list. And then once that price list is published as a benchmark, and then employers will have a starting point to work from. And if those prices are too high, you guys can stand up and say, Mark didn't do a good enough job negotiating, we'll do a better job. And oh, by the way, for all these other things we offer, they're available fee for service.
So, and you may or may not know this based on that answer. We actually have been asked multiple times, can an employer work with Cost Plus? We say yes.
Bullshit.
We do say yes. You can check me on that. We say yes to Cost Plus. We say yes to Amazon. We have a fundamental principle, which is actually why I think we're growing in the marketplace. If you're the
So what you're
employer,
telling me,
you're the health plan.
who's the legal officer here?
But remember, Optum
Hold
is
your
not
hand
the
up, please.
largest.
Because what I'm going to do is I'm going to go to all of our Optum people that we've talked to, and I'm going to say, add us to your network, because Dr. Conway said you can.
So we, look.
Because I'll add one more piece.
Yeah, go ahead.
Because we don't have exclusivities at all. None. Not one. Our price list is our price list. Everybody pays the exact same price. And if we're cheaper, use us.
Yeah.
If not,
And let me do
use
the,
Optum.
let me do the positive on you, because I'm going to try to stay positive.
You can be negative. It's okay.
It's all right. It's not my personality. I'm a nice pediatrician. So on the positive, and I really mean this, you've developed a company trying to solve a challenge. That's great. Actually, we welcome innovation in the marketplace. Let's be clear on the difference. You have a niche solution, largely in generics, that you're trying to find a lower cost individual drug at a point in time, given the complexity of the system. We have a comprehensive solution that for employers or unions or whoever else we represent, for their entire population, we negotiate the lowest net price. We deliver those savings to them. We have clinical programs, which is the difference, to make sure the right drug is the right patient. It's not just whatever drug is ordered off the internet. We find 150 million safety events a year, so real data. And that comprehensive solution, whether it's cancer or asthma or whatever the condition is, we're able to serve that population. I'll give you one more example in the specialty space to show the commitment, because I agree with you on the affordability issue. We have it's called Specialty Savings IQ, but basically using AI technology, looking for the lowest cost prices at the consumer point of care. We have saved over $2 billion for consumers. That's what you can do at scale. Out of their pocket. Let me finish.
Okay.
I'm going to have a story which hopefully you'll like. Because I get an email from a real customer, a real person, not an employer, who says, I got to tell you, I have cancer, and I was going on and off my drug. Median copay went from $88 to $5. My copay was X. I couldn't afford it. I was going on and off. I didn't want to tell my wife. It's now $5. I'm on my cancer drug. I'm healthy. I'm doing well, etc. The reason we operate at scale and try to do the work we do is whether it's a cancer patient or a kid with asthma or a person with diabetes, and this isn't a negative on your solution. Lots of solutions need to do this, but ours is a comprehensive, clinically driven solution to deliver the lowest cost drugs to over 60 million people.
It's so comprehensive and clinically driven that somebody had to email you because they couldn't afford their copay. Right, and that copay was probably higher than the cost for that medication if we carried it at cost plus.
And when we and we have done this, and
I'm sure you have. We publish our price list. Why don't you?
So on the prices, and I checked this right before because I always check facts to make sure we stick with facts. When we look at our prices, including for the drugs on your list versus our prices, we're lower almost 100% of the time.
So why don't you publish your price list?
But still, we aren't against you having a solution.
No, you're not answering the question. Why don't you publish your price list? Because my response to that is all that other stuff that you add that you think only you can do, as opposed to others being best of class and offering those same services, cost something. They're not free, and you don't offer them for free, right? And so while you look and say you're cheaper, you don't sell for less, right? You may be able to push an employer to contribute more to push down a copay. You may add the $5 that we charge for shipping or the $12 that we actually pay independent pharmacies to deliver for local pickup. But all that other stuff you do costs something somewhere. We don't have all the other mishigas.
Well, remember, Mark, drug manufacturers hate Dr. Conway, right? For a reason, right? They are not friends of Dr. Conway. I think there's a reason. The reason is you are keeping the premium low. From Medicare Part D, don't you think?
No, they're not keeping premiums low because the sickest employees contribute more.
That's exactly the reason. Yeah.
Right, because if there were nobody using drugs, brand drugs, there'd be no rebates, right?
So the rebates are on brand drugs, is that your point?
No, the rebates are paid for by your sickest members. That's the point.
So once again, and I know you're going to push me on this, but that is, you have benefit design issues that an employer decides how they want to fund their pool of employees. I used to do it when I was at Blue Cross North Carolina. I now contribute it to
I have companies I have to do the same thing.
Yeah, and so you are going to make an array of choices. How you make those array of choices, we do have rules. We didn't, if you look back, I will not speak for others in the industry. We did say the net price is a real example. We said, look, even if an employer wants to have the net price, have a consumer pay more than the net price, we're not going to allow that because the consumer should never pay more than net price. So it was one of the examples. You've been doing
consumer paying more than net price forever.
We do not. We have changed it. So you can talk about others in the industry. We changed it several years ago. I actually check about every 3 months to make sure it's new.
So what you're saying is that if the WAC of Eliquis is $600, and just for shits and giggles, the net price is $300. During the deductible phase, if I were a PBM, if I were an Optum plan holder, right, I would only pay $300 every single time during my deductible.
So you have a choice to pay. I think that's the point.
Yeah.
A choice to pay? Like I'd rather pay more?
No. So the net price, the consumer should not in our system pay more than the net price, period. So we made it as a benefit design principle as we work with them.
Should not, but you leave it to the employer so that more people cannot afford their medication.
On this one, on the net price, and we've checked this multiple times, the net price, the consumer will not pay more than the net price, period. So I cannot speak for every PBM.
So then it's not a choice.
In the country.
No, I'm just talking about you guys.
Yeah.
So the net price before all your fees that you charge, that we don't charge, obviously, to the manufacturers. So, because I've had people send me your contracts, and you guys charge your 5.45% of WAC, right? That is a fee that is not attributable to the employer. So you don't include that, but just to be direct, if the net price of Eliquis is $300 and the WAC is $600, every single person who's part of an Optum RX plan during their deductible phase will only pay $300.
You mixed a few things there, so I'm going to try to help. Yes, and because your model is most similar to a fairly small part of our business.
No, I'm not comparing to our model. It has nothing to do with us. I'm just saying if I go talk to an Optum RX plan holder,
Yeah.
and they're prescribed Eliquis, and they have an ACA Silver plan, right, which you guys sell, and it is $600 WAC for that Eliquis. They have a $4,000 deductible. How much do they pay during their deductible phase?
It's still net price. So you've asked this
I'm
like
asking
five
you,
different
so tell
ways.
me what the price is. You know the net price. I'm saying hypothetically the net price of Eliquis
It's
is
always
$300.
still the net price. So no
So-
matter how you ask the question,
I'm just
always
asking
still
for
the
an
net
answer.
price.
So just tell me, will they pay the $300 no matter what?
in your example, that was the net price. Yes, it's always the net price or
Then
lower.
When I go look up ACA prices on your formulary as for a silver plan, that's not what I see.
So first of all, I think you're mixing our formulary meaning. So we should talk about formularies at some point. So health plans have formularies. Optum RX has an independent P&T that sets a formulary. That's physicians, pharmacists, others, not even employed by Optum RX, that set the Optum RX clinical conditions and formulary tiering.
Right, but there's lots of
One of your
companies
other
that do that. But go ahead.
Go ahead. I'll let you.
So seems like, Mark, if I understand correctly, you think the obstacle to achieve affordability in the drug space is PBMs,
Yes.
rebates.
Yeah, there's a reason why we're the only country that has PBMs and our prices are higher than brands everywhere else. He wants to say, tell me if I'm wrong, that it's the damn pharmaceutical companies that are that are just extracting as much. I think it's
Do
the
you
damn
agree?
PBMs.
So
Dr. Conway, you think
no,
the
I
biggest
don't.
obstacle is
I mean, you should comment too, but no, I don't agree. And it's so if you look at the U.S. versus other countries, the biggest difference by far is in fact the pharmaceutical list price. That is set by pharmaceutical manufacturers in the U.S.
I don't
It
agree
is
with that.
generally 10x other countries on average. Look at GLP-1s and others. We then are the only actual counterweight negotiating a lower net price on behalf of our
Then
customers.
why do you have two different versions, like for a biosimilar? One low WAC, one high WAC, one high rebate, one low or no rebate.
So for biosimilars, a great example. So biosimilar adoption is going up in the U.S. The net price, including for us, if you look at net price, you see reductions for Humira, Stelara, a number of the biosimilars, 80, 90+%. We welcome that.
Yeah, but that's not the question I asked you. Why are there multiple versions?
We
So-
don't force multiple versions.
I didn't
So
say
somebody-
force. I didn't say force. I just
Why
asked
does the
why.
manufacturer
No.
make multiple?
Why do you? Because your biosimilars, you white label them, right? You have somebody manufacture them for you through Navalia or whatever the name of the
Yeah.
place.
So
right?
white
So
label-
again, it's just simple question. Why do you have drugs that are high WAC, low WAC? Why do patients pay different prices for the same drug ever?
So biosimilar, I promise I'm trying to answer your question.
That's fine.
Biosimilar, we have 4 principles that we adhere to: clinical equivalency, supply, lowest net price. We don't care about high WAC, low WAC. I want the lowest
do you
net
have
price for
two-
my customers.
Do you have multiple versions?
Not a manufacturer, but
Do you
the
have
vast
multiple
majority of our
versions
customers.
of the same drug?
We don't manufacture drugs. I'm trying to figure out what you're trying to ask.
Your label.
very simple, right?
Your label the biosimilar. Let's say, Mark, tomorrow you have a very cheap biosimilar, but then you have, Dr. Conway, you have your own label biosimilar. Would you
Honestly-
take Mark's? That's the question, right? Would you like Mark's?
That's not my question. No,
biosimilar?
I'm like, why do you have multiple prices for the same drug for different patients?
We don't have manufacturers set the price, including
So-
4 biosimilars. We will deliver the
No,
lowest.
that's not the way it works. I'm sorry. That's not the way you guys work. I'm sorry.
How do you
I think Mark's point is a different rebate, right? Different rebate situation. So net price different.
biosimilars actually? It's not. I mean, I don't mean to be difficult, but it's not correct. Like the manufacturer sets the list price.
No,
whether it's
look,
high
I talk to
WAC
the
or
same
low WAC.
manufacturers. You guys go out to bid. You go out to bid and you say, we're going to have this expected volume. What's the best price you can give us? They don't sell shit for price. You guys negotiate it.
So the only thing without naming the other companies, I think you may be mixing something. Your Lilly Novo example was a different company.
No, I know. I just was curious what you thought
Your
about.
biosimilar example, I'm pretty sure, is a different company, not us. No, there are companies that have a white label that say this is what you have to use. We have literally never done that. We do have a white label. It white labels manufacturers that set their list prices. And what we do with our customers is we say, we want you to have the lowest net price clinically equivalent drug, and they make those choices.
So you just pay them whatever they ask you for,
Once
the
again,
manufacturer. You just say, hey,
No,
we want our Stelara biosimilar to be $3,000.
if it's a biosimilar, it's similar to other drugs. The manufacturer will set a list price. We negotiate a lower net price. And in fact, biosimilars did lower the net price for consumers when they came out.
Yeah, but you're changing the subject.
I don't think so, although it's a little hard to
So,
track.
Dr. Conway, do you agree that for you to gain market share, you have to have low premium? That's your goal, right?
Yeah.
You have to try all you can to reduce the premium.
Yeah, I mean, at the end of the day,
Yeah, but you're
I
not
get
in the
it.
premium business. United is.
Yeah. So I'm in the business on the Optum side, and to raise up a bit, because I am passionate about this, I know we're all talking about pharmacy. You know, on the Optum side of the business and why we do the work, you've got Optum Health, care delivery, value-based care, you know, amazing stories if we had another time to talk about of nurses, doctors, people delivering care all across America. Higher proven evidence, lower total cost of care, lower admission rates, lower ER visits. You know, the woman south of Boston that I went and saw in her home, 91-year-old, had been hospitalized 12 times, hugs the geriatrician employed by Optum, says, now I've been hospitalized 0. I get to pay with my grandkid. She's dual eligible, Medicare, Medicaid. That's Optum Health. We got pharmacy, which we're spending most of the time on PBM, which, you know, I'm happy to talk about. There's also a whole pharmacy side of the business, which is delivering service to people, infusion, home delivery, which you do too. Great. We should both do home delivery. We welcome that. Genoa pharmacies, you know, long-term care pharmacies, et cetera. And then you've got the Optum Insight part of the business, which we aren't probably going to spend a lot of time today, but I've got to use one example in the drug space, which was Optum Rx, powered by our technology. Prior auth, which you've talked about a lot, is a friction point in the system. So we said, okay, let's partner with the various components of the system, health systems, pharmacies, and the benefit design, payers, et cetera. Average time for prior auth, median time, was 8 hours, sometimes days to weeks. Now less than 10 seconds. If there's another piece of information.
But what about the ones you say no to? How long before those get turned?
I was going to finish that if you let me. So
Go
it's
ahead.
it's less than 10 seconds approval. If there's another piece of information needed, we tell the clinician. So I mean, I was sitting in the hospital this weekend entering orders on Epic. We tell the clinician, oh, you need this additional piece of information. Enter the hemoglobin A1C, approved right away. So we're using technology to reduce friction in the system. Once again, we welcome you and others innovating around that system. We don't think we can solve everything in the system. What I would hope we could do in these forums and others is, as opposed to finger pointing or other things, how do we collectively solve the issue? Because if you look at our health system, you know, the stories I said were real. We have a child this weekend with a G-tube who can't go home because we haven't figured out effective home care in this country on a weekend. You have a child with an adolescent with a mental health disorder who gets admitted because we didn't figure out how to treat her severe depression, which is a major pain point in this issue. A baby born to a mother, and I actually predicted this, some of the people on my team will say, I will see kids with these diagnoses this weekend. Born to a mother addicted to opioids, system failed that mother, now we have the child on methadone, weaning him off. These are preventable things in our system. And so we welcome you and others helping to solve those. On the policy side, which as was alluded to, I've been in the policy environment several times with colleagues that are in the room. You know, well-meaning people trying to tackle these problems. And what I hope we do is we figure out how we tackle them together. Because I've been working on this for 25 plus years, and I kidded with my kids the other day. If it doesn't get going faster, it needs to improve faster. Because every day we're going to have people fall through the cracks.
You guys realize, and I appreciate all you've done.
I'm not.
No, I know you're not doing it for the applause.
Kudos.
No, and I get that, right? And look, between United and what you guys do, you're not going to not help people. I get that, right? But there's a reason why having 15 straight years of increased earnings, right, and then having that streak stop and the CEO gets fired or leaves and you replace them, right? There are incentives that seem to be misaligned with offering the best price for patient care. And it appears to me anyways that it's very obvious, right? And there are things like when we talk about rebates and we talk about getting the lowest net price, if you're saying you don't really do rebates anymore, it's all net price, why don't you go to the big three wholesalers and say it's really stupid that you guys are buying at WAC or NADAC, right? We want you to go to list price on everything that you do so we can buy from you, because that also helps all the local pharmacies. Maybe not the Optum RX, because you'll fully reimburse them, but would you agree that, and I know you've changed it so that 2% more, whatever, of the network gets fully reimbursed, but would you agree that it would be the right thing to do to make it so that 100% of independent or all pharmacies are fully reimbursed for their cost of brand medications?
We actually did that. So
no, you didn't.
Yeah, we did. This is like a surreal environment.
It really is surreal to hear you.
No.
Anybody
so
here that's an independent pharmacist?
No, we should. Let's talk about independent pharmacies and cost-based reimbursement. So this started a little more over a year ago. We've now rolled out to over 80% of the independent pharmacies. It's cost-based reimbursement, brand and generics, cost-plus model, to use your terminology, to support those independent pharmacies.
And what are you using as
we
cost?
Actually had
what are you
press,
using as cost?
We actually had press release.
Yeah, I saw it.
With independent pharmacists talking positively about Optum RX.
I think
not a common.
Adam Fine did an analysis of it. Do you know who Adam is?
Yeah, I know Adam.
Okay.
So it is cost-based reimbursement,
Using
standard
what is
cost
cost?
measures, so NADAC, et cetera.
Right, and is NADAC the actual cost paid when the wholesalers that won't work at a net price have GCRs?
It is actually cost-based. So it's and you
can't, because they don't even know what their cost is going to be. You understand how independent pharmacies actually buy from wholesalers.
I do.
And then you understand what a GCR is, right?
I do.
Generic compliance ratio. And you understand that there are chargebacks. So when you say that true cost is NADAC, it's not true cost, and you can still under reimburse when you do NADAC minus.
So it is cost-based reimbursement rolled out across the PSOs and true independent pharmacies. You alluded to this, but for most people in the audience, a lot of independent pharmacies are actually owned by wholesalers, or the PSOs are owned by wholesalers.
The PSOs are owned
just to be clear.
And just to add to his point, which is a great point, the big three wholesalers that dominate 90+% of the business, and I won't get, but they own these things called PSAOs that negotiate for the 5,000 give or take pharmacies that are part of the PSAOs. So the wholesalers are negotiating the price for the pharmacies that these guys are underpaying.
On the macro, which we started to get to for a second, and you should comment on this as the macro, and look, I was trained at and work in hospital. I've done primary care pediatrics. I've done lots of different things. I was trained at institutions like Hopkins. In my case, Boston Children's. The macro environment, if you look at this versus other countries, I mean, this actually isn't debatable. Hospitals and health systems in the U.S. have been growing much more rapidly than any other country.
Oh, we can get to them anytime you want, right?
And the price differential is very large.
Well, let me say we're running out of time.
And then pharmaceuticals, which we keep dodging around, there is a reality. You said 10% growing, which is true. If you look at the cost trends, and this has been put out by Hopkins and many academic, it's actually very clear what the data shows. Like the primary issue in the U.S. is hospitals and health system costs and pharmacy cost. Sorry, I can't help myself since you're getting me a little not excited, not upset.
Feel free.
I don't get upset.
Feel free.
You know, when I was at Blue Cross North Carolina, we did this work, and I literally remember as we're negotiating with the hospital, I was like, I got to go talk to your board because, you know, they were like, we need a 12% rate increase. And I'm like, I literally, if we do that, we also insure you. You'll just pay more premiums. And so I went to their board and I explained it. I'm like, this is how healthcare works. This is like how math works. If we pay you 12% more, that comes through in your premiums. And they're like, well, we don't want that. We just assumed you charge somebody in a different part of North Carolina. That is literally not how it works. So the math for the underlying costs drive the premium.
So why is it that the cash price is always lower?
For which portion of our system?
All of it?
So on the drug part, I mean, drugs, I really mean this, and then I'll let you ask your next question. On the, look, we should always look for the lowest cost drug. I'm glad you're doing what you're doing. We have Price Edge, which is our version of similar to what you do. It has saved, $275
But
million
why do you
plus
need
out
a
of-
But why do you need Price Edge when everything's already at net price
me-
because you're doing
let me
everything
fin-
at
let
the
me
lowest
finish.
possible cost?
Can I finish?
Why do you need all these other things?
So 90+% of the time, and we looked at yours, we were almost cheaper 100% of the time. I'm tempted to give you the stat.
Yep, that's
It's gonna
because of all the
make you
fees
angry.
that you add in elsewhere.
Fees
if you
elsewhere.
guys
It's
Bullshit!
buying
Like
power.
no, okay.
It's like
want me
basic
to pull
math.
out? I'll pull
It's
out.
like buying power.
No, I'll pull out. I'll pull out from your contract and read it where it says you're going to charge 5.5% of the list price. You're not going to pass that through. There'll be other fees and services that you charge for, including information technology that you'll charge for to cover and track the rebates that you create.
I'm going to try to agree with you on something. Transparency, affordability, et cetera. Ask your next question.
Yeah, so let's quickly wrap up. Let's clarify to our audience. If one thing you can change, you have all the power in DC, what would you do, Mark? Is that getting rid of PBM?
No, break up the big
Break up.
three big insurance companies.
So insurance company can no longer own PBMs, right?
Correct. You can't own PBMs, can't own providers, can't own their own technology, make them all independent companies.
That's your solution.
Because you guys own what, 10, 12% of the physicians in this country?
We actually only employ about 10 to 12,000, despite people citing 90,000. The rest are contracted.
Oh, that's a big difference.
So
Folks,
Mark,
we'll have to stop there. Let's give
No,
them a
actually,
big
difference
hand.
without a distinction.
Folks, thank you so
Dr.
much.
Conway, you give you the last word. What would be
Go ahead,
your
Patrick.
solution? What would be your solution?
Look,
you
the-
can.
Yeah, the underlying issue, just to be super clear about it, we have amazing high-level care, and it is not distributed evenly in this country, and we've got a cost problem. When you ask regular Americans, what's the problem? It's cost. And the major drivers of cost, and I'm sorry, I know we're sitting in Hopkins, hospitals and health systems and pharmacy. It's not, and pharmacy meaning pharmaceutical manufacturers, the list prices, the whole structure of the system.
And your
If we
solution?
don't, you tackle those problems. So if you look, the current administration and the one before that did a number of things around pharmaceutical pricing. You've seen announcements from this administration, you saw them in the last. We talk about site-neutral payments. Last administration, this administration. It makes no sense that the exact same procedure
That's true.
will get, 5x the reimbursement because one day a hospital bought a physician practice and the day before they didn't. That makes no sense for our system. And when you see patients, they want affordable care that's high quality. It's not that complicated.
Okay, the common ground is hospital, obviously.
Thank you so much. Let's give them a big hand. Well, folks, it's time for our final Q&A session. We'd like to give more students the chance to ask questions. So during this Q&A session, we're going to kindly ask that only those with orange wristbands, that is students, have a chance to use the standing microphones. As a reminder, a good question has 3 elements. Introduce yourself, keep it short, and end with a question mark. Thank you. With that, let's start right over here.
Hi, everyone. First of all, thanks so much for all your insights, your discussion. I love the way it was so organic, and it really it provided a very realist, non-abstract framework for how we can go about fixing these issues. Anyway, my name is Aiden Eftekari. I'm an undergrad at Harvard. My co-founder, Kareem, he's an undergrad at Hopkins. We're currently working on a startup that sort of aggregates, standardizes fragmented EHRs, particularly in ER rooms where time is of the essence, and physicians shouldn't be going through raw data and instead focus on patient care. And so our question is, across your high return investments, what non-obvious sort of habits or behavior did the founders before traction, in hindsight, most strongly, produce or express that predicted outlier success?
Go first or me? So look, I work with entrepreneurs because I find it interesting, although I'm not one. I tell people, focus, what's the problem you're trying to solve? You just hit a problem. Focus on the clinical model, which a lot of people forget. What's the clinical model? Operational model, how are you going to operate it? then financial model, and then I get to selling, which somebody else said. But you got to do the first ones first, and you better iterate fast. So my first job was improving care on one unit, and I had a mentor who said, I've trained thousands of people. Biggest thing is cycle time. Test, learn, do it faster. That's still what I try to do today with our teams, and I think it's true if you're an entrepreneur as well.
Find a customer and listen to them. You know, when someone's willing to write you a check, they're committed and they'll help you. And when you're small, that's the best place to start.
Awesome. Thanks so much. Really appreciate it, guys.
Thank you.
Great, thank you. I know this guy well, right over here.
Good afternoon. I'm James, a dual degree medical student and MBA student at Hopkins. Over the last few months, I've really enjoyed the conversations on LinkedIn between Dr. Bai and Mark, especially around direct primary care and cash pay services in healthcare. I'd be very curious to hear a little bit more about your perspectives on the current barriers to actually implementing more cash pay or pricing transparency for healthcare services. We've talked a lot today about pharmaceuticals, but I'd really like to hear more of your perspective on services.
You can go first this time.
You know that system better than I do, right?
Okay. Look, first, at the risk of annoying you on the position, this distinction does matter. We employ 10 to 12,000, then about 88,000 choose to work with us. That's what I was trying to say. Now let's
Because
get to
the people who took the actual job didn't choose to work for you,
no,
right?
no, they're contracted with multiple entities. Optum pools and provides them tools. That's why I choose.
Do they
So
do what you
actually
tell them to
lead,
do?
Which actually they're independent. They choose what they do. So let's answer your question on direct, because I think it's a really interesting one. Look, I think that kind of innovation around sort of cash pay, et cetera, is super interesting. So we work with 100 plus payers at Optum. A number of them are even saying, like, how do I use, and they all have different names, various systems that are both on benefit and off benefit. The price edge thing I mentioned earlier is on benefit, off benefit for RX. When I say off benefit, meaning in the cash market. I think that, whether it's been various companies in direct primary care that have subscription models or other models, I think those models are super interesting to think about, implement, et cetera. The one caution I'd give us is an equity issue. So, some of those models have served a certain segment of the population that has cash and resources and not other segments. I just think then as a country from a policy perspective, we have to figure out, how do we address the whole population, not just the population that can afford cash pay.
I'd say transparency, real transparency, and simple things, and I'd be curious what you think, allowing people to go out and get the best price for care and have it automatically count against their deductible. Are you for that?
Yeah, I actually think some of your ideas of how you have it count against the deductible, both in pharmacy and medical, I think are very interesting.
Interesting, or
I don't run a payer anymore. If I ran a payer, which I don't anymore because it's actually, then yes. Like if you had intervention and I was running a payer and I say, oh, I can put this in and I'm going to count against the deductible, yes, I would do that.
But you talk to the guy who does run the payer.
I serve 100 payers, of which one is United Healthcare. That is correct.
Right, so you talk to the guy in charge of United Healthcare, right?
Yeah.
And so would you tell him that it's a great idea that everybody who goes out there, and if Cost Plus is cheaper, great. If Optum RX, one of your pharmacies, is cheaper, no matter what, if you buy it and have a receipt and send it to the payer, to the insurance company, it counts against your deductible.
Yeah.
Cool, so you're gonna tell them that?
I do. This is fun for me. I hope it's fun for you. I don't get attacked this much.
Not an attack, it's a request to improve the system.
Yeah, so yes is the short answer. So if you think about, to be clear though, and I know you're...
Can I get invited to that meeting?
Sure, no problem. It's an actually interesting thing because people, look, we partner with United Healthcare, but we do partner with 99 plus other payers. Those conversations are pretty similar. People think they are like literally, like what happens is not what you might imagine. For United Healthcare, they are pushing Optum very hard for the best deal possible on all things, including Optum RX. So is every other payer in the country. So actually the dynamic is a little different than people might imagine.
Yeah, but there's 75%, is it, of your user base?
No, is the short version. It depends on the various businesses, but we're usually, like in RX, it's about 50% external and 50% United Healthcare. United Healthcare is larger just because they are a large payer.
Thank you. Let's hear one question from each side here, and then give you a chance to quickly address both of them. This will be our last question. If you could briefly introduce yourself and share your question, and then we'll have you please introduce yourself and share your question. Please.
Yes. Good afternoon. My name is Dr. Shondell Knights, and I'm a fellow in Ward Infinity, John Hopkins Ward Infinity program. And okay. And I'm also the first naturopathic doctor to accept insurance, so thank you, Optum, because you guys made it possible. But here's my question. When does it become more important to focus on preventative medicine, using things such as like a wearable that we're trying to develop to prevent kidney disease? DC has the largest kidney disease in the entire country. When do we focus on preventative medicine, and when does that become more financially advantageous over all of this back and forth about drugs?
Okay.
Great. Before we do that, could I hear your question over here? We're going to do them both together.
Absolutely. Thank you for a great conversation. My name's Kadamba. I'm a first-year MBA. I guess my question will be a little more directed towards you, Patrick. Just a few days ago, we were doing a case for our class in which we were looking at the PBM space, and the transparency issue was coming up, right? But beyond just the conversation, we also started touching upon the pieces that different technologies are talking to one another, and vertical integrations bringing together different systems, where pharmacies are now talking to PBMs, who are talking to health plans, who are talking to insurers, and everybody is trying to get together. How much of a technology issue do you see in today's world that data that is fragmented all over the system is not able to talk to one another? And what's preventing the current solutions to bridge that gap?
Okay, I'll go first on both, I guess. So prevention, couldn't agree more. Thank you for your work. Then I think, and actually in our value-based care models, it enables the financial model now allows us to invest in prevention. So the example I gave, if you're taking a % of premium from the payer, which is generally what we're doing, then across our system, we can invest in physical care, mental health care, preventative care, social determinants of health, et cetera. So thank you for your work. I think, like we've heard in others, prove the various intervention works, which I'm sure you will, then we should invest in that, and we do at Optum. The data one, and I really want to hear your answer on this too. Look, and I'm still an AI learner. My son probably knows more about AI than I do, but I'm learning and trying to learn fast. As you think about AI and technology and the data pieces, I gave you a few examples. I think it will unlock significant value and decrease friction in the system. So Optum Real is one of the things we rolled out a few months ago. All the benefits are digitized, all the clinical protocols connected to health systems. Alina Health was one of the first ones, and they talked about how over 99% approval rate instantaneously, and if another piece of information was needed, it told the clinician and they could enter that piece of information. That's the kind of system without friction that I think the technology should unleash.
Yep, I'll defer to you on the first one. You're the expert there. In terms of data and AI, yes, AI is going to change everything and is changing everything. The problem is it's also going to be siloed, because John Hopkins doesn't want all of its IP being used by Mayo Clinic in a model, and both of them don't want their IP, nor does Optum want their IP being used by ChatGPT or Gemini or Grok. And so rather than publishing everything like we did in the past, people are going to hold it back and put it behind a firewall or put it within their own models. And so we're going to see a world where it's not just 5 of the big foundational models. There's going to be tens of thousands of models, and everybody will have their own, and that will create its own problems. And you'll have meta models, right, where we try to get in front of them and pull from the appropriate one, and it's just going to get really complicated. And so for specific applications within a specific universe, within Optum as an example, it's great. But in terms of changing the world, we're going to run into some roadblocks.
We'll have to leave it there. Let's give our panelists a big round of applause. That was great. My sincere thanks to Professor G. Bai for bringing us all together. Thank you, G. We appreciate you. Really quick, I'm also grateful to the Johns Hopkins Carey Business School events team, the Office of let's give them a hand. Thank you. The Office of Faculty and Research, the Hopkins Bloomberg Center, and all the volunteers who helped bring this session to life. Thank you all so much for joining us. Look forward to seeing you again soon. Bye-bye, everybody.
Also, thank you, Stephen Cohen, Professor Stephen Cohen, for such a great host. Thank you. And Merry Christmas, Happy New Year, everybody. Thank you very much.
Thank you all.